for your talk. Basically, I'm a clinician. I'm standing here with a great pleasure to give my knowledge about the splints and braces among the well-known academicians. Why I selected this topic is many of the students are not aware of what is splint and what is brace. Not the students, when I'm a BPT students, nobody has taught me what's the use of splint and what's the use of brace, and they'll just come and tell hi-fi terms and go. So I just thought of explaining this to all the students, my beloved students. Thank you. Actually, a splint and orthosis is a word we used to use like interchangeably. It's actually splint is it can be either a piece of bamboo or paper which help to immobilize a part. Orthosis means we apply our anatomical design and mechanical principle and dynamic forces into that. This is the common difference. So let us start the webinar. As I said, like what is a splint? A splint is a rigid support. Either it can be made from metal, plastic, or plaster. I think all of you know that. You have come across a lot of splints, tennis elbow splint, thumb spiker splint, cocker splint, and so many splints in our day-to-day physio practice. It helps to support, protect, and immobilize, and also to prevent the deformity. We can just say it is corrective, preventive, and retentive, according to the patient's symptoms and signs. Indications for splinting is, mainly we can use it for joint infections, for example, in septic arthritis or any joint infections, then tenosynovitis, like decuvarence disease, then acute arthritis, sprains, and fractures. Main use is to immobilize the part, either to increase the range of motion, or either to immobilize the part, or to assist the power in paralyzed patients too. So how do you classify splints? Actually, based on the mechanical principles, we can divide the splints into static and dynamic. You can understand from the word itself, static means no movement. Dynamic means it gives movement. Then, based on the joint involvement, we can classify into articular and non-articular. Then materials used, molded and conventional. Like if you we can say custom made. Custom made is the splint, what we give to the patient according to their size. Then based on the anatomical parts, we can divide it into wrist and hand orthosis, foot orthosis, finger and thumb orthosis. We can divide the splint according to the part we use. Then I will explain what is orthosis. Orthosis is a mechanical device which helps to keep the in anatomical position. As I said, leads to support, prevent, or correct deformities. It also lends stability to the weak joint and also corrects and maintains alignment. Commonly used materials are aluminum. Like, what's the biomechanics of orthosis? How do the orthosis help? It modifies the system of external forces. So, as a physiotherapist, when you design an orthosis, these are the points you have to keep it in mind while prescribing or designing an orthosis. You have to modify the system of external forces. And also, we have to control the movements across the joint, and axial forces around, we have to control the axial forces. And I will be explaining in each and everything in later slides. And also modify the point of application and also the line of ground reaction force during static or dynamic weight bearing. That helps when you design a foot orthosis or when we design the orthosis for gait training. Then first we will see what is static or resting splint. As the name implies, static means it's a rest, to give rest to the part. I think most of the people have seen this cocker splint. Used at night, we can give it to use at night. I have no moving parts and prevent the motion and also to support the splinted part. Then second is dynamic splint. Dynamic splints are nothing. It's a moving or functional splints. It permits the movement. Usually dynamic cocker splint is used after the tendon repair or post-traumatic tendon injury rehabilitation. And we will use it in the wrist drop also. And keep joint in the joint position and helps to increase the grip strength. The narrow plane splint. Narrow plane splint is nothing, maintains the shoulder in abduction and external rotation. We used to give an F patient and also the paralysis of deltoid muscle. The other splints what we use are static serial splint, serial progressive splint, especially in case of burns. Then Cocker splint. Cocker splint is used to help to stabilize the wrist in functional position. Main used conditions are wrist drop, carpal tunnel syndrome, and wrist arthralgia. The knuckle bender splint. That is nothing, it bends the knuckle, that's all. No need to mug up the word. Like, it keeps the MCP in 90 degree and IP in extension. Main indications are total claw hand and ulnar claw hand. Reverse knuckle blender splint is just the reverse of this. Then C splint. C splint means maintains the thumb in abduction and partial rotation. It stretches the wrist space, especially it prevents the contraction of the thumb used in median nerve injury and burns. And also it helps to maintain the palmar arch. Opponent splint, as the name indicates, maintains the thumb in abduction and rotation under the second metacarpal, and the wrist and fingers are free. Used in dequerence and Bennett's fracture. Bennett's fracture is the first metacarpal fracture and opponent's transfer. Then trigger finger splint. Trigger finger, as you all know, the tendon comes out of the pulley and gives the patient a snap while extending. So there are two kinds of trigger finger splint, usually MCP joint blocking and DAP joint blocking. Usually giving a splint for trigger finger patients are not much more beneficial. We will give the splint when the patients are not ready for surgery in near future. Those who want to do the surgical release for A1 pulley. Then swan neck deformity splint, especially hand splints are more useful in treating hand arthritis patient in OA and RA. It is a swan neck and also sometimes in stroke patients to correct the deformities. It is a metal and oval shaped orthosis. It helps to keep the DIP in normal position and also the PIP joint stability. While putting the splint, you can do some function in the fingers too. The main cause for giving the splint in RA patients are ulnar deviation or drift. I think you all know it. How it happens is, it happens due to the synovitis at the MCP joint, due to the stretching of the surrounding muscles. So the hand will be going to the ulnar deviation. So whenever you design your orthosis for the hand, ulnar deviation or drift should be kept in mind while designing an orthosis. So splint, how it helps in ulnar drift, it helps to provide the passive realignment of structures. This is a oval 8-finger splint, helps to maintain, treat trigger finger, mallet finger, swan neck, botany deformity, and also arthritis. These are some splints used for mallet finger and stack splint. There are also other splints like finger extension splint, frog splint. These are all the splints help to immobilize the finger in finger injuries. These are all the evidences while using the splints in upper limb. Usually they have shown a good results by using the night splints in reducing the pain. Okay, as a physiotherapist, how do you check your splint is proper, or how do you check? These are the common points we should check while giving or prescribing a splint or orthosis to the patient. FACS, it's an acronym. F means function, whether the splint satisfy the need of the patient. Then you have to check for the pulse, then capillary refill, and also the temperature and sensation. You just check whether it's limiting any movement or is there any tightness around the joint or muscles. Tick. Then most of the patients used to ask how to care the splint. How to care the splint? Splint means check for the skin redness and check for the allergy of the material used. Usually off-the-shelf splint, that is the splint what we take from the ready-made branded, they will give some allergy to some of the patients. Just ask them to check the skin redness or soreness. And ask the patient not to wear if they cause any pain or rubbing or any symptoms increase. Clean it with a damp cloth or wash it by removing the metal bar. Most of the patients, they don't know when to remove, how to use it. So, as a physiotherapist, better spend 1 or 2 seconds to explain to them. Then, coming to the upper limb orthosis, based on the anatomical region, we divide it into shoulder and arm orthosis, elbow orthosis, wrist orthosis, and hand orthosis. First one coming is clavicular orthosis, that is clavicular base. As you all know, it is a figure of 8 and helps to restrict the motion in the clavicular fractures. And also it helps to improve the posture and reduces the scapular pain. We will use in clavicular fractures and thoracic outlet syndrome. Then commonly what we use is an arm sling. Why we give an arm sling is, it prevents the overstretching of glenohumeral ligaments and muscles. So, the elbow should not be in the extended position. If we keep the elbow in an extension, it will produce a dependent edema. So, whenever you give an arm sling, just make sure that elbow is in the flexion position. Common indications are acromioclavicular joint injury and humeral fractures. Then this is the elbow wrist hand orthosis. We use to immobilize the elbow wrist to promote tissue healing. Then coming to the lower limb orthosis, as you all know, we divide into ankle foot orthosis, that is AFO, then knee ankle foot orthosis, KFO, then knee orthosis, and floor reaction orthosis, especially in case of foot drop. Then CRO, and this last one, CRO is Charcot restraint walker, that is in case of Charcot's joint. First, coming to the ankle foot orthosis, that helps to control the movement of foot and ankle, and especially patients affected with muscular dystrophy and cerebral palsy. Usually, in our clinical practice, while giving an ankle foot orthosis, please assess the power of quadriceps. If quadriceps power is more than 3, so there will be use of giving AFO. Otherwise, go for KFO, that is knee ankle foot orthosis. As the name indicates, knee ankle foot orthosis comes above the knee, and there will be a lock provider. Lock will be of 2 types, drop locks. Drop locks means when the patient sits, the lock drops automatically, or the patient have to release the lock. There are the type of KFO or supraquadraplastic orthosis, Scott-Craig orthosis. The knee orthosis, it's like nothing but like a type of knee immobilizer. It extends above and below the knee joint, provides the functional support. We always used to give to the patients in rehabilitation for the surgery of the knee, ACL injuries, TKR, that type of patients. There are 3 different types: dynamic patellar orthosis, traditional knee orthosis, Swedish knee cage. The knee immobilizer, you should have all come across. It is a fabricated metal insert for stability, mainly for the pain relief, a ligamentous laxity, if there is any quadriceps weakness. It restricts all the motions of knee. Then HKF4, used for hip flexion and extension instability, paraplegic patients, and also hip internal rotation, external rotation instability. Then reciprocal gait orthosis then is given to the upper limb paralysis in which active hip flexion is preserved. Then plantar fasciitis splint, it's nothing but to give a rest to the foot. We can give MCR sandals and night splints to plantar fasciitis patient. Thank you. Then next orthosis, what we use is commonly what physiotherapists use is foot orthosis. Like how do foot orthosis help? Like depending upon the pressure inserted, we can classify into soft, semi-rigid and rigid depending upon the flexibility. Soft means it's a flexible foam type, gives cushion. It all works under the principle of pressure and force of area support is given. Then rigid means strong and stiff, helps to assist with the transfer of weight. and stabilize the flexible deformities. I'm not going into detail to explain biomechanical principles. How it helps, it maintains and supports the existing arches and also provide the inversion-eversion balance and reduce or limits the pain and also prevent further joint destruction and support and stability while accommodating the abnormalities. It should be light in weight, proper size, and perfect alignment. While designing a foot orthosis, always keep it in mind of a ground reactive forces acting on the joints. Always give the foot orthosis when it is indicated, and it should be functional during the phases of gait. That is an important point you should remember. Then orthotic ankle joint should be placed over the tip of the medial malleolus. Then this is the one, how in RA foot pain comes. Lifestyle modification, joint inflammation. Due to that, what happens is valgus, arch flattening, or splay foot. We can say it's a pes cavus, pes plano valgus, and pes planus. Pes cavus is nothing but like medial longitudinal arches heighten, like increase in the medial longitudinal arch. Then pes planus is loss of a longitudinal arch. Pes plano valgus is, due to that, the foot goes into valgus position. For that, what are the shoe modifications what we give us? Usually in a shoe, there is a lot of part like inner sole, outer sole, toe box, heel, like that. So while making a shoe modification, so just see to that, where do you want to do the modification? Either in the inner sole, because orthotist is the person who designs according to your like instructions. So excavation of inner sole is what we do in plantar fasciitis. Then ulcers, plantar callositis, especially in diabetic patients. Then metatarsal pads. While giving a metatarsal pads, so metatarsal pads should be 3 by 16 inch height and which is placed proximal to the metatarsal head, so that the weight will be transferred from head to shaft. Then insoles, the metatarsal bars, alex rigidus, and hammer toes. Whenever the patient comes with the foot pain, always check for the footwear what they use and also the weight bearing of the patient. And then these are the metatarsal inserts available in the market, and also the metatarsal bars, how we design. Then we modify the heel. Thomas heel and flag heel is the common one. Thomas heel means it's nothing, but medial aspect is 1 inch forward, so that it supports the medial longitudinal arch. Then flare heel means lateral part of the heel is slightly elongated to support the lateral side of the foot. Then MCR sandals, it's used in patients with the sensory loss. It is a soft sole. It is padded with microcellular rubber. Then upper limb, next to upper limb and lower limb orthosis. Next is spinal orthosis. Common spinal orthosis is a collar, cervical collar. Cervical collar has 3 types: soft cervical collar, hard cervical collar, and Philadelphia collar. Soft cervical collar as such, it limits the movement and restricts, and Philadelphia collar also does the same, but the design is different. Then Taylor's brace and LS corset and ash brace. It's a types of collars. I'll be explaining one by one. Soft collar is nothing, as the name indicates, it's made of soft foam. It is basically a psychological support. It's a relief from minor muscle spasm. We will say it's a reminder to the patient. It supports the head and also relieves the neck strain. Then hard collar, it is a semi-rigid one made up of plastics. It gives, it provides little more stabilization to the cervical spine than soft collar. It includes the occiput and also it helps to decrease the range of motion of neck. It's mainly used in stable spine conditions. Then Philadelphia collar, as you see in the picture, it has a hole in front. It is mainly for the tracheostomy. It's a neurological patients when we give the Philadelphia collar, so there should be a hole in front to support the tracheostomy tube. Then next is SOMI brace. SOMI brace is given in upper thoracic injuries. It is anterior chest plate extending from xiphoid process, and it covers the shoulder. It is mainly for the bedridden patients, and also it doesn't have a posterior rods. Then LS belt, it is a flexible one. It designed to limit the motion. It acts on the 3-point pressure system and also helps to reduce the pain. Then TLSO, that is thoracic lumbosacral corset, that is otherwise called Knight-Taylor's brace. It's mainly for post-operative stabilization, chronic back pain, and also for the lumbar fractures. Especially in our osteoporotic patients, when they come with the compression fractures, we usually describe TLSO, that is Knight-Taylor's brace. That's all. Thank you all. Hope you just got an idea about what a splint and orthosis.
It's a good presentation for the UG students, particularly to know the importance of orthosis and splints, particularly in the rehabilitation. Yes, very, very good presentation, ma'am. Thank you.
Good morning, ma'am. It was like summarizing for both UG students and PG students once again after a long time. I hope students would have benefited, ma'am. Really, it is a nice presentation from top to bottom, like starting from head and neck, trunk and lower limb, like fingers, what are the splints and orthosis available for our purpose, for rehabilitation purposes. I hope students, they should have benefited if they have observed this. Thank you, ma'am. Thank you.
Thank you so much, ma'am, for this great session. Now I invite our chairpersons to honor our session speaker. Thank you, ma'am. Thank you, chairpersons, for concluding the session. Next, I would like to announce that sport programs are going to get conducted at ground. All the participants are requested to report at ground. Sport sessions and sport programs are going to conducted at ground. All the participants are requested to ground. Next, we would like to start the award ceremony. Everybody, please be seated. We would like to honor the resource persons. We are going to start the award ceremony. Please be seated. Sports programs are getting conducted at ground. Interested participants are requested to report at the ground. Only registered participants are requested to report at ground. Sports programs have started. All the registered participants are requested to report at the ground. Professional excellence. We're going to present Professional Excellence Award. I request Professor Andrew Miltons on stage. Next, we request Professor Ramya ma'am on stage. We award Professor Ramya ma'am for professional excellence. I request Professor Andrew Miltons on stage to collect the Professional Excellence Award. I request Professor Arun Tachal to receive the Professional Excellence Award. I request Professor Arun Tachal. Associate Professor Susan George ma'am to receive the Special Appreciation Award. I request Associate Professor Susan George ma'am. I would like to announce that paper presentation is starting at Hall 2. I request the participants to report. Scientific sessions are starting at Hall 2. I request the participants to report at Hall 2. Scientific sessions are starting at Venue 2. I request all the participants to report at Venue 2.
Attention everyone, all the programs from Venue 3 have been changed to Venue 2. All the programs from Venue 3 have been changed to Venue 2. Now we are going to start the next session. Everyone please be seated or remain in the seats. Leading towards our next session, which will be commenced by our speaker, Dr. Venkatesh K., Professor, Mahatma Gandhi College, Pondicherry. The chairpersons for the sessions are Professor Darius, Luth Institute of Medical Science, and Associate Professor Anija Ma'am, Luth Institute of Medical Science. He would acknowledge us on the topic sports nutrition.
Good morning, everyone gathered here. So myself, Venkatesh, and today I'm going to present a topic about sports nutrition. Nutrition, everyone might have an idea what to consume and what can be a healthy food. But in an aspect of sports person and as an athlete, you'll have a certain sort of doubt that what that a profile or elite athlete will consume. Do you have any idea what Virat Kohli will have for a breakfast or what Rafael Nadal will have for a lunch? We don't know any idea, isn't it? So this session will give a small insight about what kind of food or a nutrition that athlete will consume. So start the session. So first session is going to be an introduction to a sports nutrition. Sports nutrition plays a vital role in enhancing the effects of physical activity or performance regardless of any sport. It focuses on adequate hydration and fueling before, during and after training. So this again become a myth here. What athlete consumes before the session and what they can eat during a session and what during the resting period what they will consume. So based on that there are three type of athletes has been classified. The first one is an elite athlete and a well-trained athlete and a recreational athletes. Elite athletes are the one who plays sports as their full-time profession, and well-trained athletes are who plays in the club or college level, and recreational athletes are those who always also called as weekend warriors, athletes who train to improve their health and lifestyle. Mostly we will come under this recreational athletes. The requirements of each athlete vary depending upon their training level, body composition and sports, and it's necessary to fuel them accordingly. So I would like to add a point here which happened, which I experienced with, all know Ambati Rayudu, a cricketer who plays for CSK. I had a chance to talk to his nutrition advisor, and he said that I was very curious and asked him what Ambati Rayudu consumes in the breakfast and what other players in the CSK team will consume. And the answer that he gave actually given me a shock that our Virat Kohli, in a week, he consumes only 2 spoons of rice, steamed rice. He consumes only 2 spoons. It really gives me a shock that how unhealthy we are following foods. Being a South Indian, our staple food is rice, where we consume more amount of carbohydrate. But inside that, Virat Kohli only consumes 2 spoons of rice in a week. That really eye-opener for me. And then I curiously started asking him what others will eat. And most of them say that unanimously I came to a conclusion that their food has been categorized as 20% of carbohydrate and then 60% of proteins, and the remaining 20% they consume fat. That is a conclusion I draw from the data that I collected from nutrition experts. And then important guidance on nutritional strategies can have a negative impact and may hinder performance, increase the risk, and injury may lead to poor recovery. Next, what are the benefits of sports nutrition? It helps to train effectively and provides the energy to complete this session. It improves body composition. It promotes muscle building and recovery. It maintains good health of athlete. It reduces risk of injury, and it promotes immunity. So these are some benefits of sports nutrition. And next, we'll have a small idea about what are the nutrients. So this, everybody might have known this, what is macronutrients and micronutrients. The major carbohydrate, proteins, and fats comes under macronutrients, and all those minerals and trace elements comes in micronutrients. Along with this solid foods which we consume, hydration and the liquid intake is also a vital part in an athlete's regimen. So, and then timing of the nutrient consumption is also a factor here. So what they consume before the training, in what proportion they will consume, and during the event what they will consume, and after training what they will consume. So mostly before training, a combination of carbohydrate and proteins in the form of beverages and snacks to saturate and activate the muscle contraction. For example, before the session, they will mostly have a peanut butter sandwich and then a fruit or a dried food with nuts, butter, nuts, and fruit juice and nuts. And then during the session, they mostly go for liquid foods, mostly electrolytes in the form of beverages to prevent dehydration from fluids and sweat loss. For example, 6% sport drinks, which are readily available in the name of Gatorade. Many sports drinks are there, where there will be a 6% of carbohydrate will be there. Or else we can make 6% of carbohydrate sports drinks with the help of a lemon juice with salt and sugar, or a coconut water with the salt can also help in rehydrating. And then post-training, mostly they will consume a combination of carbohydrate and protein. So from this, what we came to one conclusion is, before the session, mostly they will go for a carbohydrate in the form of beverages, not in a solid form. And during the session, mostly they will go for a carbohydrate, again in a liquid form. And after the session, they will go for mostly a solid form, where they can have a chocolate milkshake, protein shake, eggs, fruits, or even our staple food, rice, all comes under the post-training sessions. So this gives us a small clarity to you, I think. So what an athlete consumes before the event is mostly carbohydrate in a liquid form, and then during the session again in a liquid form, and then in a post-training mostly they'll go for a solid form foods. And again, during continuous session, it is important to focus more on recovery to reduce risk of muscle tears and injury. So they follows a triple R here, RRR. One is a refuel and one is a repair and rehydrate. For refuel, adequate carbs and calories to promote muscle glycogen resynthesis, and then repair, adequate proteins to repair muscle tissues and promote muscle protein synthesis, And to rehydrate, adequate fluids to hydrate and replace the lost fluid and the sodium through the sweat. So these are the 3 R's that are followed during this session. And then from this, what we can come to a conclusion is adequate nutrition and guidance is necessary for an athlete to improve performance and promote recovery. It possesses several benefits to an athlete. Consumption of micronutrients is equally important as it plays a major role to promote recovery and muscle growth. Not every athlete is the same, and their requirements may vary according to their physiological needs and sport-specific needs. The 3 R's of recovery of refuel, rehydrate, and repair. And next, we move to what is the balanced diet here. So balanced diet, we know healthy balanced diet is important of good health, whether you are a professional athlete or a recreational athlete. Making proper dietary choice can optimize training to reach performance goals. It is also important to consume a wide variety of foods to get all the necessary nutrients of normal growth and development. So the balanced diet should be a proportion of equal amount of macronutrients as well as micronutrients, where the main nutrients that provides energy, carbohydrate, 1 gram will mostly consist of 4 kilocalories, and protein will be again similar to the carbs, and fat 1 gram will be containing 9 kilocalories. And here carbohydrate is much known topic, so I'm not going to go in details there. So carbohydrate, we know, which is the primary fuel, which is an instant fuel, which gives an instant energy, which has been classified into 3 groups. One is monosaccharides, which is glucose, fructose, and galactose. And then disaccharides which contains 2 molecules of sugar, which are broken down into monosaccharides. Either it may be a combination of sucrose glucose, or a lactose glucose, or a maltose glucose. Polysaccharides, also known as a starch, which is readily available in the form of potatoes, and it's formed from many glucose molecules. Carbohydrates can also categorize as a simple and complex carbs, and according to glycemic index, the GA of a food is referred to a food's effects on a blood glucose level. They are classified into low, moderate, and high glycemic index foods. So in carbohydrate, what they consume before the training is carbohydrates stored in the body as a glycogen in the muscles and liver. The stores are relatively small and needs to be replaced frequently. It not only fuels training, but also optimizes recovery. So carbohydrate is much needed energy, where it is readily available in the form of fresh juice, which is extracted. 60% of lemon juice can also help you regaining the carbohydrates. The timing of consumption also impacts the performance. Before training is essential to increase carbs availability during exercise. It stops to high glycemic index foods as a pre-snack. Avoid fiber-rich foods as they cause stomach discomfort. So this is again a myth here which we tend to follow here. So eating a diet, fiber-rich foods are healthy, but not the timing of the dietary fibrous food is to also be considered here. So mostly during a session, they will avoid eating fiber-rich foods. Hence, it may lead to a stomach discomfort. Even in our elders and the grandmothers used to say, don't eat fiber-rich foods like green leafy vegetables in the night time. Simply because it takes more time to digest, as well as it creates a stomach discomfort also. So what they will go for is watermelons, breads, dried fruits, sports drink, and glucose. So during training, this we know the Gatorade drinks are there. 30 to 60 gram of carbohydrate per hour should be maintained throughout the session, or else it will lead to a muscle cramping or as well as dehydration also. So readily available 600 ml to 1200 ml of sport drinks are available, where 4 to 8% carbohydrates every hour by the means of squash or a glucose drink or raisins or apricots can help during the training session. And after training, the best carbohydrate which can be advised is banana, a sweet potato, and then fruits. So recovery is most important part of training, and carbohydrate intake should start as soon as possible. This can be through liquid or snacks containing 1 to 1.2 grams of carbohydrate per kilogram of body weight. So, protein, again, as important as carbohydrate, protein is essential for growth and repair of muscle tissue. So, as an athlete who keeps on training for the whole day, so they tend to develop a micro trauma inside the muscles. So, it needs an adequate amount of protein to get repaired. The protein which are absorbed as an amino acids, there are 20 amino acids present, on which 9 are termed as essential amino acids and forms complete proteins. Animal food sources are called as a complete protein, whereas the vegan proteins are mostly considered as an incomplete proteins. So the examples for proteins are eggs, yogurt, chicken lentils with rice, peanut butter, sandwich and milk. Okay, the protein recommendation may vary from person to person, 1.2 to 1.7 gram per kilogram of body weight, and it depends upon the athlete's sports and game position, training phase and body fat control. For an example, if you take a marathon runner who doesn't need a big amount of muscle bulk, so his requirement of protein will be comparatively lesser. For a normal individual, 1 gram of protein is enough for 1 kilogram of body weight for a normal daily to-day activities. But in case of weightlifter, the proportion may vary. 3 grams of protein per body weight might be required here. So based on the sports and based on the person's requirements, the protein intake may vary, but it is recommended for 1.2 to 1.7 gram per body weight. Protein consumption before and during training has not been beneficial to improve performance. So unlike carbohydrate, which gives an instant energy during a session, before or during or after the session, carbohydrate have a much more significant effect instantly. But on a longer run, protein will be having a delay, which takes time to build a muscle. So it don't have a drastic impact over the performance, but on a longer run, protein will have an impact here. In addition to muscle growth, protein is also required for muscle recovery. This is enhanced along with muscle protein synthesis when consumed along with carb source immediately after exercise. It is necessary to include some fats as it provides essential fatty acids. So fats, again, there is a confusion. Consume of fats will make you obese, or it will gain weight. Again, it is a myth here. Fat is also as important as carbohydrate and protein. So dietary fat is made up of 3 fatty acids, mostly the saturated fatty acids, monosaturated fatty acids, and then polysaturated fatty acids and essential fatty acids. And the sources has been mentioned there also: cashews, beets, olive oil, and sunflower oils. So essential fatties are divided into omega-3 and omega-6 fatty acids. Focus more on omega-3 fatty acid as consumption of omega-6 tends to lower HDL level. The requirement depends on body composition and training level. Most athletes tend to keep fats on a lower side to maintain body fat percentage. Simple adjustment like opting for a low fat ingredients, skimmed milk, and lean cuts of meats and fish are advisable. It also reduces calorie intake also. Example, a salmon, fish, nuts and seeds, olives and avocados. So again, micronutrients. Micronutrients are equally important as macronutrients. What we discussed before is macronutrients, the carbohydrate, protein and fats. The trace elements and the micronutrients is also as much important as the macronutrients here. Micronutrients are equally important as macronutrients as they improve health and physical performance. Consuming a diet rich in fruits and vegetables provides the required vitamins and minerals. Vitamins are required only in a small proportions and are classified into water and fat soluble. The fat soluble vitamins are vitamins A, D, E and K. Water soluble vitamins are vitamin B and C. So here are the vitamins and food sources. You can have a look at it. So most of his, you can see eggs will come in most of the vitamins, as well as greens, peanuts. You can see the most common food among all those vitamins might be eggs, eggs, cheese, and dairy products. So which will cover almost all the vitamins. And the liver of goat will almost cover all the vitamins, all the B1, B2, B3, B5, B6, B7, all those vitamins will be covered if you consume a liver of a goat. And again, all those vitamins and its sources. So I think vegetarians are a bit cursed, I think. Most of the vitamin sources are from the meats and eggs. And minerals are also required in small quantities which help in normal body functioning. They are required in milligram, and mineral required in milligrams are called trace elements. Trace elements like calcium, phosphorus, magnesium, sodium, potassium, iron, and zinc. And again here, what are the minerals and its sources? You can have a look at it. So again, a default is dairy products, and again eggs will come in most of the minerals, and then seafoods also comes in the source as a source of minerals. Here again, manganese, selenium, iodine. Again you can see fish here, milk here. So what if micronutrients are consumed lesser than needed? It will lead to some certain deficiencies. Athletes who train vigorously or vegetarians are not fueling adequately tend to have a micronutrients deficiency. This has an impact on body function and exercise performance as well. Supplementation is required, but it is important to not exceed the requirement, as it may be toxic. As there is a old saying, too much of anything is good for nothing. Particularly the fat-soluble vitamins, water-soluble vitamins are passed through urine if consumed in excess. Most athletes tend to deficit in iron, vitamin D, and B12. Particularly vegetarians, and supplementation is a practical approach to correct them. But supplementary foods are not recommended mostly for an elite athletes, as it leads to a secondary complications. However, do not resort to taking supplements if it can be consumed through a food. Once there is a source of food is available naturally, it is not mandatory, or it is not necessary to consume as a supplement form. So this is some tips that will be helpful for you. So read the menu before going to a restaurant to be aware about the food choices presented. So don't get fooled by a colorful presentation over in the menu. Just go through the menu and choose your food accordingly. Have small portions of food. So if you go to a restaurant, don't order single food in a huge proportion and consume it largely. Instead, you can order so many dishes and make a proportion out of it. And opt for a steamed, grilled, or a boiled food instead of fried to reduce calories from fat. So if you are willing to have a So if you are willing to eat food, try to be opt for a steamed food, grilled food, or a boiled food instead of fried or to reduce a calorie from fat. Include more vegetables and whole grains instead of refined foods. As one of our research say, in India had become a diabetic hub simply because they are opt for a refined sugar larger than any other country consuming. As for sauces and condiments on the side, and limit sugary drinks and go for a low-calorie beverages or a flavored plain water or even a coconut water will be beneficial. So the next topic will be hydration. How important hydration is in the field of sports nutrition. The water makes up 60 to 70% of our entire body. It helps to maintain blood volume, regulates body temperature, balances sweat loss, and act as the main transport to carry nutrients and waste products. This unit will discuss about hydration and its parameters. So we all know water is important, but how do we calculate how much of water drinking will be beneficial in case of sweat loss? To hydrate effectively, it is important to drink fluids more than a sweat loss and also replace sodium loss through sweat. The best way to monitor sweat loss is to weight oneself before and after exercise with minimal clothing. Each of kilogram weight loss is equivalent to 1 liter of sweat loss. For effective rehydration, it is important to consume 150% of the lost fluid. So this is a calculation here. If you take an example, a person is 70 kilogram, and after a session after a training session, the person's weight is 68.2 kilogram. So the weight difference between the pre and post workout is almost 1.8 kilogram. And fluid loss in ml, as I said before, 1 kilogram is equal to 1000 ml of fluid loss. So he lost 1.8 kilograms, so the fluid loss might be 1800 ml. So we had to replace the lost fluid in 150% of the weight loss. So 1.8 kilogram is lost, so we have to replace by 2.7, that is 2700 ml of fluid has to be replaced. So this again, it is a calculation before, we don't know idea, no, how much of fluid is lost, how much we have to replace. We simply take fluid to quench the thirst. But here what the calculation says is, you have to check your body weight before as well as after the training session, and how much of weight loss is equal to 1000 ml of fluid loss, and match it with the 150 ml of fluids. So that's the calculation. So urine analysis will give us an idea whether you are hydrated or you are lacking of fluid. A pale urine color indicates that an athlete is well hydrated. Not only athlete, it is applicable for normal individuals also. If you are having a pale urine discoloration, you can say that you are well hydrated. In case you are having a darker urine output, it indicates the athlete is dehydrated. The chart can be used to measure hydration status of an individual. So 1 to 3, which comes under a pale color, which indicates the person is well hydrated, and 4 to 6 is little in the mid range, so which we can say is moderately dehydrated. And 7, 8, we can see there is a darker color of urine, so we can say they are severely dehydrated. So hydration as well as the climate will have an impact also. See, you can see me now. I'm not doing any workout here, but still I'm sweating like anything. So climate will also have a severe impact. One of the bigger challenge for an athlete is to stay hydrated in hotter temperature also. This is due to excess sweat loss than usual, which may have severe effects on performance. Replacing sweat loss during exercise is critical and more important in such climate. A common strategy used by athletes in consuming cold water or a slurry drinks, this can help maintain body temperature along with effective hydration. It is also crucial to replace sodium lost through sweat, as it maintains fluid balance, helps absorb nutrients, maintain cognitive function, nerve transmission, and muscle contraction. Approximately 2300 milligram of sodium is lost through sweat in an hour. So imagine how much of sodium we will be losing in a summer here. So not simply drinking of water can replace or hydrate you. We have to add some sort of sodium also to your regimen. So how we can know that the person is dehydrated? Dehydration means excessive lot of water from the body through sweat. Replacing sweat loss through adequate consumption of fluid is necessary to prevent symptoms of dehydration. Mild dehydration is generally refers to 2% to 3% of loss in body weight in water. This impacts normal functioning of body, which is indicated through the symptoms listed below. So these are the symptoms of dehydration. Thickening of blood, so hence the viscosity of blood gets thickened as it finds difficult to carry the oxygenated bloods to all parts of the body, and increased body temperature, which will result in further sweating. It will again dehydrate you more. And lightheadedness, you can see The person will be normally irritated during a summer period, as like me. And then nausea, fatigue, and impairs physical and mental performance are the other symptoms of dehydration. So dehydration will have a direct impact over the sports performance. So it keep on increasing thirst. As you can see, the IPL is going on. Most of the players from abroad are feeling the heat actually, same as the Indian players also. Due to increase, there will be a frequent, every 2 hours there will be a drinks break has been declared in this year IPL. So increased thirst, decrease in blood plasma and urine output, 20 to 40% degree in physical performance capacity. It impairs concentration, there will be a loss of balance, they feel exhausted and fatigued, decreased strength, power, endurance and cognitive function. Heat stroke that can also sometimes lead to death also. So keep yourself hydrated. So again, how an athlete can be hydrated before a game. 4 hours before the exercise, what they will give is 5 to 7 ml of fluid per kilogram of body weight. So you can imagine if a person is 50 kilograms, so you can multiply it by 5 or 7 ml. So that this is recommended 4 hours before the exercise. Just before 2 hours of exercise, the portion will be reduced to 3 to 5 ml per body gram. So simply because of more amount of fluid, it will results in dehydration. So during the game, what they will drink is the main aim to drink fluid during game is to prevent dehydration. Aim to drink enough fluids to prevent more than 2% loss in body weight. This is a calculation which we already discussed here. 150 or 250 ml of fluid has to be given every 15 minutes. You can calculate according to it. For exercise that are longer, that exists for longer than an hour, it is advised to consume 30 to 60 grams of carbohydrates per hour. And this can be achieved by consuming isotonic sports drinks containing 4 to 8% of carbohydrates, which are rapidly absorbed. It also helps to reduce fatigue, maintain glucose levels, and also improves performance times. In addition, sports drink can also contain sodium to replace the loss of electrolytes as well. So this is a recipe which we can make very easily at home also. Take a orange, squeeze for 250 ml and add a plain cold water for again 250 ml. Almost equal proportion of juice with an equal proportion of water and a pinch of salt. Mix through and take a sip during the session. This will hydrate you more than what you require. So post-game hydration, again, after a strenuous activity of more than 6 hours in a field, one has to be hydrated. Again, the calculation which I said in the slide 4, 150% of fluid has to be replaced to overcome the hydration. A moderate intake of sodium is equally important post-game as it helps with effective hydration and also stimulates thirst. Post-games, avoid having caffeinated beverage or alcohol post-game as they have diuretic effects and also increase the risk of injury. So this again, there is a study has been conducted, Ashes, you know, a rivalry cricket series that was played between Australia and England. So after every match, they used to consume champagnes. And then the next match, there has been identified there is a greater amount of the drop in the performance of the athlete. So they found that there are consuming more amount of caffeinated drinks, which increase the diuretic effects. They will keep on losing the fluid, and that will have a direct impact over the sports performance also. So as an example of post-game drink, a chocolate milk, that will be good, as it is a perfect combination of carbohydrate, protein as well as sodium. So summary of this entire session is, start every session well hydrated, way before and after session to calculate the amount of sweat loss and fluid required. Check urine color frequently to figure out hydration status. Limit fluid loss to less than 2% to prevent dehydration. Consume cold water fluid during hot climate to aid in thermoregulation. Aim to drink 150 to 200 ml of isotonic drinks containing 4 to 8% of carbohydrate to improve performance and reduce fatigue, and replace fluid by consuming 150% of sweat loss along with sodium for an effective rehydration. So these are the references, and thank you.
Thank you, Dr. Venkatesh, for a wonderful presentation. And sir explained about the sports nutrition in detail, and it was really a brainstorming section. Thank you, sir.
Good morning, Venkatesh sir. The presentation was very delightful and informative. And we all know that nowadays the importance of involving someone in sports is very increasing daily. But no one is much bothered about what nutrition they should take in a daily basis to maintain their body or to maintain their strength or agility, something. So I think, sir, you gave a deep knowledge or in detail what a person should consume during during the pre-training, during the training and post-training, and also about the importance of hydration. Okay. Then the micronutrients, of course, we cannot neglect micronutrients. The importance of micronutrients is very, we all know that it's very important in our daily intake. And usually we neglect the importance of micronutrients, but you also covered that very well mannered then. And also about the urine analysis. That was very, that's a very basic knowledge we'll get how much we get hydrated during each and every session. Okay, I hope the audience also got very knowledge about the sport-specific nutrition. Thank you all for this wonderful session. Hope you all enjoyed also. Thank you, sir. Thank you.
Thank you.
Thank you so much, sir, for this great session. Thank you, chairpersons, for concluding the session. It's time to hand over the memento to the scientific session speaker, Dr. Venkatesh, sir. I invite Professor Daris ma'am and Anija ma'am to hand over the memento. Welcome you, ma'am. A black color conference bag is missing. Everyone please check if it is here somewhere. It contains a phone and certain informations. So everyone please check a black color bag, conference bag.
My dear students, ഇന്നലെ ഒരു ബാഗ് കളഞ്ഞു പോയിട്ടുണ്ട്. അതിൽ ഒരു EMS കോളേജിൽ നിന്നൊരു കുട്ടീൻ്റെ ബാഗ് പോയിട്ടുണ്ട്. അതിൽ മൊബൈൽ, പേഴ്സൊക്കെ ഉണ്ട്. ദയവ് ചെയ്ത് ആർക്കെങ്കിലും ഉണ്ട് മാറിപ്പോയതാണ് അറിയാം, അതൊന്ന് റിട്ടേൺ ചെയ്യണം പ്ലീസ്. താങ്ക് യു.
Special announcement, attention everyone. Chess and Carom are being held. Reported first floor, JDT Islam College of Physiotherapy. Attention everyone, chess and Carom are being held. Report at JDT Islam Physiotherapy, first floor. Scientific research have started at venue 2. Scientific research sessions have been started at venue 2. Attention everyone. Guess the name. Pictionary competition is being held. Anyone interested can report at first floor of JDT Islam College of Physiotherapy. Guess the name. Pictionary competition is being held. Anyone interested can report at first floor JDT Islam College of Physiotherapy. Thank you. Moving forward to our next session, the chairpersons for this session are Professor Manju Unikrishnan, Little Flower College, Angamali; Dr. Jayashree Ma'am, Head of Department of Physiotherapy, Anandapuri Hospitals and Research Institutions. The session keynote speaker is Dr. Annie Thomas, Director, Physiocare and Research Coordinator, School of Health Sciences, Garden City University, Bangalore. She has a total experience of 20.4 years in academic, research and clinical work. She has worked and contributed in upliftment and welfare of many established institutions in the past few decades, including St. John's Medical College, Bangalore, JSS College of Physiotherapy, Venkata Padmavati College of Physiotherapy, Ramakrishna Mission Vivekananda University, and many more. She was awarded SAS Fellow Membership Award for the contribution in academic and research in 2021 July. received GSU Puraskar 2021 in the field of research and academics, received assisted world record for the greatest number of topics in free live international webinars as resource person and many more such awards. She has done many presentations and was resource person for plenty of national and international conferences. She would enunciate us on the topic ICU management in neurosurgical conditions.
Thank you so much. Thanks, Dr. Sajeevan, for giving the opportunity to share my knowledge on the topic on ICU management in neurosurgical conditions. Thank you for chairing my session, Jayashree ma'am. Ma'am, thank you. So, basically, most of you must be knowing about the ICU management. So what I does means I'll just generally say about the ICU, then I'll move towards the management side. So as you all know, when you say about ICU, it is meant for critically ill patients. And it is in a different section wise, and mainly when you try to approach, there are different kind of healthcare professionals will be dealing with ICU patients. So there will be sophisticated environment where we have to monitor and we have to manage the patients. So in different areas, there are different terms are used. Some areas they call it as CCUs, some areas they call it as traumatic units or trauma centers, or sometimes they will use as ICU in general. It is basically for the patients to recover from the crucial area and has to move towards the daily activities. That's what the main area to make the patient overcome the dangerous situation. So whatever may be, it is a neurological conditions or it may be a cardiorespiratory conditions or simply it may be an orthopedic conditions which may be affecting their cardiorespiratory or the brain. So when we say what are the patients who are in the ICUs, not only with the neurosurgical, we cannot say it is only with brain injuries. But if the brain injuries plus there is a multiple organs which is involved, they also will be in ICUs. And a serious accidents. So basically when you come to the neurological conditions, the brain injury or head injury which can cause, or after the spinal tumors or the cerebral tumors or cerebellar tumors which can again come to the neurosurgical areas or neurological areas. Sometimes as neurological conditions like we commonly say stroke, which must be due to hemorrhagic bleed, might have been evacuated and they need evacuation of the hemorrhage which has happened in the brain. In that case also there will be neurosurgical areas. And if you see the other conditions like spinal conditions, any fractures of the spine, or if there is a intenting of these fractures into the spinal cord level, or even sometimes there is a entrapments of the nerves which must be causing the spinal cord lesions. So it can be at this cervical level, it is little more dangerous because as you all know, autonomic dysreflexia and other things which can cause damage to the patients. So that may be the reason they will keep them in a neurosurgical unit. And one more category comes into the spinal conditions is by the neurosurgeons, they does laminectomy and discectomy of different levels of spinal regions. That also needs a support which they will put them in a neurosurgical ICU. So it's not only the brain or the brain injuries or the stroke which has been given or got the surgery or brain tumors or other conditions, but in these cases also they will be in neurosurgical areas. Other than ICU conditions is your burns or any cardiopulmonary arrest, your poisoning, drowning, all these conditions will be there in ICUs. So when we deal with the ICU patients in the neurosurgical areas, basically as you all know, ventilator will be there, which has got different modes. We say it starts from the CPAP, a basic thing, to SIMV mode and all these things which is adjusted with the PEEP. Okay, all that things would have been adjusted, depends upon the patient's situation, the ventilator supply would have given to the patients. And one more thing is, other than the ventilator, there will be a normal oxygen supply also must be connected to the patients, or we say CPAP, which also will be connected to the patients. Monitoring equipment for any conditions usually will be there in the ventilator, because as we know, when a brain injury comes or a brain insult comes, we need to check the intracranial pressure. Intracranial pressure, some of the good hospitals may have an intracranial monitor. It would have been connected to the monitor and we will come to know what is the cranial pressure. But sometimes some hospital may not have, but we can have a look into the systolic pressure where it indicates what is the pressure, or indirectly it may be representing the brain pressure. So always it will be connected to the monitor. We need to see the heart rate. So sometimes even the patient is unconscious, the patients would have been in some stage of conscious which they are not able to respond, but they will be knowing. So when you try to move your limbs or when you try to facilitate any kind of movements, the pressure variance may show the heart rate also is increasing. So that is one way to notice for us to say that patient is able to respond. That is how we can indicate. As a clinically experienced person knows much about it, we can indicate clearly by the systolic pressure, or we can see the SpO2 is raising, or also we can see the heart rate is increasing. So such situations, when you must have checked the ICU GCS conscious levels also, you might have got maybe E1, M1, V1, or you might have got E2, M2, and V0. Either they would have been in tracheostomy or they would have put eustachian tube. But still you can see when you try to move the lower limbs or upper limbs, you can see there is a variation comes. There we need a monitoring equipment, especially when a neuro patient, when we are assisting, we should have always a look at monitoring equipments. IV lines and pumps, you all must be knowing about it. Sometimes if there is a hypotension or if there is a hypertension, usually they will administer drugs like adrenaline or noradrenaline to maintain the levels. So always there is a pumps and always IV lines will be there. Feeding tubes, we need to have always a look whether some neurological conditions they would have given oral tubes or Ryle's tube. Sometimes they would have given an abdominal tubes also for feeding the patients. Drains and catheters. Drains in neurological conditions, what happens in the case of a head injury with multiple traumas. Suppose for the patient has coming to you with a head injury and you can see a catheter which is coming from the lung side, which may be due to a pneumothorax or a bleed inside, they will be draining out. So as a neuro person going into any critical care unit, you should not think I am specialized in neuro or I am going to treat only neuro. You should see that the patient has a whole unit. That means they should look over the cardiac conditions, they look over the musculoskeletal conditions, and also they should see the brain levels. So all the tubes and catheters, drains are very important for us. Usually, if you go to a neurosurgical ICU unit, there will be an intensivist. Why they are required? Because neurosurgery surgeon may look after the patients for all the status, drugs, everything. But always the patient status may not be same throughout the day. So there is an intensivist, always can administer drugs, or whenever there is a requirement for any additional thing, patient intensivist can manage. That's why always most of the hospitals, multi-care hospitals will have an intensivist. And a physician, nurses, and for us, ICU physiotherapist. So we should know what are the common infections. See, sometimes if it is a busy hospital, it's like a government hospital, or if the beds are more, the number of nurses may not be ratio. So for example, usually in neurosurgical ICUs, 1:1. That means one nurse will be managing the one patient. But if you go to a busy hospital, instead of one patient, they will have 5 patients. And 5 will be critically ill. So when you go to the ICU, never think that you are a physiotherapist, you don't need to look into other things. No. You will be acting as a whole person over the ICU as soon as you enter. So any infectious things, even you can modify. So for example, when you go to the patient and patient is having fever, you will write in the notes, the patient is having fever, so I'm not going to treat it. You write the patient is contraindicated for physiotherapy, you write the notes and come out. No. You should think what must be the cause for the infection. See that whether they have notified what is the indication. whether one of the most important thing is pneumonia. Pneumonia, you know, most of the times the collections will be there in the lungs and it may cause infections. Sometimes the lines which is going, that means it may be an IV line or it would have been a jugular vein line, they would have put it, or femoral vein, they would have put it. Sometimes there is a catheters. These all can cause infections. If the patient is gone for laminectomy and discectomy also, when you are going to treat the patients, always first check the surgical site for any inflammation around it or any infections or any oozing out is there. Such cases, what you should do means, you should inform the nurses this is the thing and you should write in the notes what you have observed prior to the treatment. Never say that it is contraindicated, you can't do it. See, why you are not doing when the patient is having fever? The thing what's in your mind is the inflammatory process which is maybe due to anything will increase. That's the reason you say when the physical activity comes, again the blood will be rushing into the different part of the body and inflammatory proceedings may increase. That is the reason why always we say fever is contraindicated. But it doesn't mean that a patient is having a pneumonia, we can't move lower limbs. We can do. Okay, patient is with pneumonia is not contraindicated for physiotherapy. That indication is only for meant to that area where pneumonia is affected and whether it is an acute state where you can't do a drainage or any manipulations over that area. That is the only difference. Doesn't mean that you can't move your upper limbs or you can't position the patients. You can't teach deep breathing exercises or you can't teach the lower limb. You can't do mobilization. Such things are not contraindicated for any patients. So when infections are there, we should know what is the type of the infections patient is having. Based upon that, you change your protocol, what you are using day to day. You can always change it. That's why we require infections. Many times the patient, we have a wrong assumption that the patient is connected to the mechanically or patient is in SIM mode and you can't do, the PEEP ratio is high, I can't treat the patients. It is nothing like that. If the patient is in the ventilator also, you can mobilize the patient to sitting and standing. This is from my experience I'm saying, and this is from the knowledge what I have treated the patients I'm saying. Doesn't mean that patient is in a ventilator, you can't do anything. The only indication is in the neurosurgical patients, the monitor levels you need to check whether the systolic pressure is increased or less and SpO2 is below 80. So for neurosurgical conditions, we usually say 80. If you have SpO2 up to 80%, we can mobilize. But see to that 80% is not dropping. So suppose if you are in a ventilated patient, if you are mobilized to 45 degrees of inclined position, and SpO2 is maintaining up to 91, or you might have seen it is going to 85, that 85 is maintaining to 15-20 minutes, you can give exercises in that period, no issues. The sudden dropping of below 80 or below 90 should be careful. Below 80 at the most, you should put back the patient into the same position to avoid the hypotension. So any patient who is in a ventilator, deconditioning, when I say deconditioning, it is not the muscular atrophy or muscle wasting. The lungs, the heart, everything is going for deconditioning. When we, as a physios, we always look into contractures or deformities or such things. But in this case, what we have to look at is even the lungs, the capacity is going to decrease when the patient is in supine lying for a long time. The muscles are going to be wasted. Thereby, you may get complications like contractures, deformities, such things. And if you are not weaning out the patient from ventilator, if the patient is in ventilator for a long time, patient may go for something called as ventilator dependency. These things we need to be avoided. So improving the quality of the life of the patient from the ventilator to the normal level is a physiotherapist role. The doctors will give drugs, the nurses will do the dressings, but a physiotherapist's job is to make the patient to wean out from the ventilator to the normal air oxygen. So that is our contribution comes. So these are the common contraindications. Sometimes the mood alterations in neurological conditions, you can see lot of mood variations. It depends upon what is the brain situation. Other things, if the patient is from ventilator for a long time, almost you are going to see on the 6th day or 8th day, we can see the muscle weakness would have been started. We can see nerve weakness is there. Body is becoming very lean because the muscle mass is reduced. And you can see a lot of adipose tissues. That is, usually we can see some conditions, when you go for a neurological conditions, you can see there is a hypertrophy of, there is a calcification of the bone inside the muscle tendon, which causes reduction of pain and a reduction of movement and lot of pain, that which we call it as heterotrophic ossifications. Such kind of secondary complications will be there if the patient is there for a long period of time. So basically, there are many reasons why the different syndromes in the previous slide. Maybe due to skin wounds which the patient is not able to move. So that may cause the movement is reduced. Or a lot of edematous, there is an incontinence, prolonged immobility, or patient is in a coma. So when you go to the patients, this much complications you should reduce. When the patient is, when you are in the ICU, you should see to that there is no deconditioning. You should see that there is no ICU related weakness. Deep vein thrombosis, you might have heard from your first year or second year of BPT that deep vein thrombosis has to be avoided. Muscular atrophy, neuropathy, respiratory complications, even when you are in supine leg, you know it is gravity assisted position and the diaphragm will go for weakness. So that is also very common. Contractures, pressure soles, and this all lead to reduction of the quality of the life. When you see all these aspects, later on you can see the patient is go for functional decline position. As much as you are not treating the patients, you are going to increase the patient's hospital stay. So length of the period of patient stay in the hospital is increased by our physiotherapist. We should not do that. What is our use? We can think of physical improvement in the patients, respiratory improvement in the patients. We have to see that discontinuation of mechanical ventilator, which we call it as weaning of ventilator. We should avoid the patient's bed rest and improve the health status. So when you go to neurological conditions, as I said, it is not only to assess the neurological areas, we need to see the assessment of the cardiorespiratory condition of the patients. We need to assess the musculoskeletal aspect of the patients, and thereby you are treating the patients as a whole. We say critically ill patients. So lung function you need to improve, as I said. Ventilator associated pneumonia is very common, which is due to our negligence, which we need to reduce. And we should improve or facilitate the weaning of the ventilator and promote the early discharge. So what is the thing we should do? You must have heard of ICF, right? You must have heard of International Classification of Functional Disability and Health. Based on this category, we can categorize the patients, where is the body impairment and what is the things to be done, what is the activity, what is the participation, what is the environmental factors which is inhibiting, everything can be classified. When you do that, you will be able to know how to assess the patients. For example, if you go into the ICU, you are going to get a head injury patients. When you see the head injury patients, you are getting a patient little agitated or something. So when you see the patients, and you must have seen splints in the lower limbs, or you see some drains from the lungs, or you see there is a splint over the upper limb, you should assess not only the GCS, you need to see the musculoskeletal assessment. See, for the patient with a GCS, if the patient is not developed spasticity, or the patient is not having any form of movements, you should assess the motor of the patients. The sensory you may not be assessed because the patient may not be comprehend to tell you what is the sensory awareness he is having. But motor you can do. You must have seen many doctors will go and ask the patient put out the tongue out. But if the patient is on a ventilator or the patient is not conscious, how will you check the motor? So you should see the movements. Whenever there is a stretch happens, you see that which area of the body is moving. Is the area is moving or the other part of the body is moving? there we can categorize them to have a general mobility is there, or general motor recovery is going to come, or general motor awareness is there in the patient. If the patient's lungs, you need to assess patients, you need to auscultate all the lung areas to see that where is the secretions. Based on the secretions, you can do postural drainage. So it is a wrong assumption that the head injury patients should not be changed. Head injury patients, when they are in the ventilator, if the things are stable, we can change the position. The only monitoring area we need to look at the tubes, the drains, everything which is connected to the patient, plus your systolic pressure and SpO2. Suppose the systolic pressure, when you go to the patient, it is 180 by 680, or if you are going to get 200 by 80. You cannot say that it must be kept such a way that the head should not be tilted down. If you tilt down, what happens? Again the pressure, systolic pressure will rise up, because there is again a blood rush to the brain. So in such cases, we cannot put the patient's head down. So when you do the postural drainage, the head tilting down for such patients may be contraindicated. That's the only difference. But if the patient is maintaining the systolic and diastolic pressure normally, and if you tilt down also the pressure is maintaining, or if you incline also there is no dropping of systolic pressure, definitely you can do a position-wise drainage. If the patient is having a lung injury, or if the patient having a fractured rib, or if the patient is having an acetabular fracture or lower limb fractures or scapular fractures, such times we may not be able to position to that side for a drainage positions. So polytraumas you need to take care, plus the SpO2 levels and BP variables you need to check when you do the change of position to do the postural drainage. So that is what we should remember. So there the term comes red flags. So when you come to the ICF, there is something called as active range, passive range. If the patient is unconscious, when you ask the patient to move, they will not move. So you can't do active range of motion. But always check patient passive range of motion to avoid any further contractures. The patient is not going to move. So if you are not going to mobilize the patient and maintain their joint range of motion, if the patient is going to come back or come out of the ICU with the contractures, it is the fault of a physiotherapist. So we should know how much for that patient's normal range of motion, whether day to day you are going to maintain that range of motions and muscle maintenance. That's why we need to check. And it is not from your assumption, you should check with goniometry itself. Suppose if the patient is able to respond for a muscle or joints, then you check the manual muscle testing. Suppose that the patient is able to respond to your commands in neurosurgical conditions or in stroke which is undergone surgery, then what you should do, you should ask the patient to move it and see what is the grade for it. Okay, here I have put hand grip strength and all for 3. Above 3 means you have to give the resistance. So for such things you can use the hand dynamometer or whatever it is. If the patient is able to move and you can see a catch kind of sensation, then you have to do a spasticity assessment. If there is an assessment of spasticity or you feel there is a spasticity, then go for Ashroth grading. Any patients in the ICU, don't go into the assumption and check the motor power or check the mass. Any neurosurgical patients, any neuro patients, I should do Ashroth scale. That is a wrong assumption. When there is a neuro patient, sometimes they'll be able to, they would have been in a hemiparesis state and they would have recovered. So we have to see the patients as first to see that whether they can move it. And when you mobilize the patients, you feel that a passive range of motion is restricting something, understand whether it is a rigidity or spasticity. As you know, spasticity means there is only one direction, there will be catch and release. But if it is a rigidity, when you do both sides, that means flexion or extension, if you do, there will be catch and release. So first you have to decide whether it is spasticity or rigidity. And if it is spasticity, definitely what you should do, you should go for a Ashroth grading. If it is rigidity, you have to classify what is the type of rigidity. So any neuro conditions, first do the motor assessment to check which category the patient is. According to that, you have to do it. This has to be correlated with the reflexes. If the reflex is going to exaggerated and you say the patient is having spasticity 1 or 2 plus, it is correlating. And if you say the reflexes are normal and you say the spasticity is 2 plus, then it is not correlating. That means either in one of the side you have done something wrong. So always your spasticity or your reflexes or the reflex mechanism, what is happening in the upper limbs or lower limbs will be having a, correlation. Whenever patients are there, edema means it is something to by musculoskeletal system. No. You have to check what is the type of edema. Sometimes if patient is not moving, you might have got distals. That means your hands or foot, there will be lot of swelling over there. So you have to see, is it bilaterally you have swelling. See, if it is a dependent edema, both upper limbs should have the swelling, right? And both lower limbs on the ankle area also there is a swelling. But if the patient is gone for a hemiplegia or hemiparesis due to the neuro conditions, what happens? The active limbs may not having swelling, the abnormal limb, that means the affected limb may have swelling. So before going for checking, you should decide whether the patient is having hemiparesis or the patient is unconscious and not moving at all. Sometimes what happens, the patient when you go there, there will be edema, but you can see both upper limbs or lower limbs or one side limbs would have been tied to the bed. In such conditions, you should understand, you don't remove the slings and try to do passive movements. Most of them does that mistake. The patient legs and hands are tied because the patient is agitated. That means the patient himself is moving that limbs. You don't need to move. You need to move whether the other side which is not tied to the bed. There it is required. And when you go to the patients, another thing what you can see is bed sores. It is not nurse's duty alone, it is a physiotherapist's duty. If you see a discoloration of the skin, you have to inform the nurses. You have to write in the case sheets what is the redness over that area or which area you have seen. It is your duty also. So see to that, bed sores. You know bed sores, if you give rest, again it is going to be more. That is one thing. Conscious level or cooperation. This is one important thing. Any neurosurgical ICUs, you can see some patient will be totally paralyzed and not moving at all. Some patients' limbs and everything would have tied. The tied patients are usually agitated. They may try to pull out the drains or they try to pull out the catheters. That is the reason they have tied. So such case patients, you have to check the RAS scale. That means what is the level of consciousness. Sometimes this patient already agitated and they would have tied, and when you go and assess the Glasgow Coma scale, it looks like the patient is E1, M1 and V1. If you write, you are wrong because they would have given sedation drugs to the patient. Patient is sleeping, that is why your GCS level looks low. So when you go to the patients, just check the patient's case sheet at the back side, what is the drug list they have put it. Okay, when they have administered the drugs, that is very important. When you go to, suppose for example, if you are getting, I don't know how it is, but most of you might have got an ICU patient for your exams. And when you assess the patient, you will get all the scores less. When the examiner comes and call out the patient names, the patient may open the eyes. So why it is? Because the drugs given during your evaluation time would have been deferred from the patient, the examiner who has come for the evaluation time. So that time the patient would have come out of that sedation state. And some patients, when they are agitated, if they are in a brain bleed state, their bleed will increase. So they will try to sedate or try to sleep the brain so that more amount of bleeding will not happen in the brain. So such situations, we can use the RAS scale. And you say the patient is not cooperative, so I am not given the treatment. This all are our experience I am saying. So patient is, you see that patient is not cooperative. When you ask something, the patient is shouting at you, or patient may kick at you, or patient may pinch at you. You see what is the started cooperation they have. Based on that, you can plan out your treatment. That is why the assessment should include this also. The other one is sensation. If you go with the cotton and try to put it and ask for it, the patient may not respond. So you have something called as modified Nottingham sensory assessment scales, which can be used in ICUs. Functional activities. The patient is supine, but the patient can go for a rolling on the sides. That is a functional activity of the patient. That means the patient can do that much. Your level is from the sideline, how can you make up the patient to sit? If the patient is able to sit with your support, then your next level of treatment is to improve the static and dynamic balance in that sitting position. So that is why we should know what is the patient's functional activities first. Based on that, we can plan out. If the patient is able to walk with support in the ICU, then we can go for DE Morton Mobility Index. And as you all know, for the exertion, we can use box scale. These are the important ICU scales which you can use it. One is functional status score for the ICUs, that is to understand how much functional activity is already maintained in the patient's body. The second one is physical function outcome score. This scores, if you use it, if you get a case, in future also, most of you are coming up, it doesn't mean that you have to do an RCT and publish the paper. It is not required. If you are going to treat one patient in the ICU, you can publish that case into a paper and you can publish as a case study. How? You should have an outcome measures to measure that what you have done initially has been changed when you taken at the level of taking the patient from the ICU to the ward. For that you require some amount of scale, or you should use the outcome measures. That's why this kind of scales are used in ICUs, because if you ask me film to be checked in ICU, maybe I'll get only a 0 score. I may not get anything. But in ICU scores, many ICU mobility or physical functional outcome measures, you will understand what is the level was there in the ICU, and when you are going to wean out the patient and make the patient go to the ward, what is the status? That's why. 6-minute or step-up test and all can be used in the ICU itself if the patient is cooperative or the patient has weaned out, and you can do it. So 6-minute may not be possible for a neurological conditions, but you can start with the 2 minutes, then you can do 4 minutes, then you can progress to different kind of things. It doesn't mean that patient is having an oxygen tube and you can't make the patient to stand or walk. You can do it. Only you have to tighter the oxygen tube. Suppose if it is 5 liters, the patient was given for 1 liter. The patient, when they get up and sit, you can see SpO2 is dropping out. You can increase to 2 and you see that the level is maintaining. Then you give the exertion exercise at 2 level. So that's why we will grade it. So with the oxygen supply, you should improve the patient's lung capacity by tightening the oxygen levels. So these are the basic important things when we give physical activities. You can do sitting activities, you can give different balancing, static or dynamic balance things you can do in the sitting position, but only check the heart rate or what is the status of the cardiac conditions, blood pressure, oxygen saturation, etc. These are called a relative contraindication. Doesn't mean that this many are there, you can't give physiotherapy. This is relative. That means if the patient is having a decreased level of awareness or consciousness, what is the kind of exercises you will give, where you should give. If the patient is started profusely sweating, if the patient is a C1, C2 fracture or C3, C4 fractures, that means somewhere it is contraindicated, you need to take care. If the patient is suddenly the face color is changed due to frighting or flighting responses due to a spinal cord injuries or even to the brain insult, you have to be cautious. If there is severe amount of pain, which the doctors have not noticed some amount of fracture in maybe a distal finger, which they would have been looking to the neurological conditions, they would have ignored small areas. We need to check. Fatigue. If the patient, when you give the exercises 5 or 6 times, the patient is getting very much or very bad fatigue. If there is an unstable fracture, you should not try to move. Okay? These are the things. Some of the lines in the body which we need to take care. Most of the neurosurgical conditions you can see in the first 2 days there will be a drain. Or if you go to a spinal cord laminectomy or discectomy or spinal tumor or any conditions, you can see a drain which is coming out to drain the fluid which is already accumulated due to surgery. So such period we need to take care of the drains. Don't try to compromise the position for any kind of activities. So the intervention itself, you can give different things. You have called active intervention, you have got passive interventions. See, most of the things, it depends upon the patient's conditions. You can change whether you need to give active or passive. What we do generally, so posture is one of the thing. The patient is supine doesn't mean that you have to maintain that position. We can change the position based on the parameters. Passive limb exercise or active limb exercises, when you check it, active limb exercises is patient's voluntary movements. So they know how much they can move it. But when you do the passive limb exercises, even if you overstretch, the patient will not be able to respond. In such situations, as a physios, we need to see that excess stretching of the muscles are not happening, which may injure the muscles, which can go for hypertrophic ossification, which is very common in biceps area, which is very common in thigh. These two areas, usually you can see there is, and next 2 or 3 days when you go, the patient will not allow you to move that segment because it's already an inflammatory process happened. So passive limb exercise, when we give, see to that a normal limb, how much it goes, that much only. You should have the thing. Rotational therapy, when you see, if the patient's spinal segments are normal, you should do pelvic rotations, otherwise the pelvic floor muscles or the core muscles will go for weakness. So always do rotations. Muscle training, when you think not only the passive movements or upper limbs, you need to train the respiratory muscles in different. Suppose if the patient can be inclined to 45 degrees or 90 degrees with ventilator, you give exercises not only in supine position, incline to different positions and start giving breathing training for the patients. So there you can adjust the PEEP or there you can adjust the CPAP or BiPAP, depends upon what is given to the patient. Thereby you can increase the respiratory effort from the patients. Peripheral muscle training, because the distal atrophy is very common, so we need to give how much our movement is possible. You set the exercises. It is not like only the progressive resisted exercises you will give repetition maximum and do it. No. If there is a neuro case also, if you see in the ICUs or anywhere, if the patient is able to do active movements without resistance, then you see that is the repetitions, you should, how much repetitions, how much frequency, how much intensity you should give, decide and give. That is how you train the maximum motor recruitment. So that is very important. In ICU itself, you can give neuromuscular electrical stimulation so that you can avoid more of atrophy in the muscles. Airway secretions management, there is no specialization over here. Any neuro conditions, you should be knowing how to train the respiratory muscles. You should be able to, if the patient should be able to manually hyperinflate, and then you can give postural drainage for the patients. Percussions and vibrations can be given with moderate intensity if the patient is not having a rib fractures or patient is not having a pneumothorax or any lung contusions. In such cases you can give. In exhale sulfation also you can give. Intrapulmonary percussive ventilation also you can give. So these all exercises are indicated for neurosurgical conditions. When you see the mobilization, see to that each positioning. Suppose if the patient is able to sit for some time, the mobilization is maintenance. The patient is sitting erect against the gravity. So how much time you can maintain that period? It is not only making the patient to walk is mobilization. Any positioning, the patient is adapted. From that adapted position to the next level, if you are able to move it and gain that movement or movement or the functional position, that is very important. So that is how we can do it. If the patient is not neurosurgical patients, we can use the prone position, which will help the ventilation of the lungs. But neurosurgical conditions, it is not indicated to put them in a prone position. Patient mobilization, progressive changing of the movements, everything is very important. In ICU, if you get a patient with spinal cord injuries or laminectomy or discectomy, or even after a neurosurgery, see to that your treatment start from the first day. If the patient coming from the post-op room to the neurosurgical ICU, you should be able to move the lower limbs. This will activate the patients. Only see to that the systolic pressure is not increasing much, which may bleed the brain. This is the passive things you must have seen a cycle on the bed, which we does cycling in the bed. If the patient is able to do the lower limb movements, we should make the patient do it, or we can do a passive cycling. Standing also is one of the mobility activity. Static walking, if the patient is on an oxygen supply, we can make the patient to stand and we can ask them to march in that place. Make the patient to learn from transfer from bed to chair, walking and cognition. Most of the times we say cognition is psychology. No, cognition is also one of the area for us. We need to manage, depends upon the patient's cognition status of the patient. They may shout at you, they may kick at you, they may pinch you, anything they will do. But see to that how you can improve the cooperation with the patient and what things you can do from your side. So whenever you see, it is always say, if the patient is in ventilator also, we should give maximum mobilization program, and we should not be late more than 1 or 2 days. That's why I said first day of the neurosurgical conditions, we should treat from the first days. It should not be more than 2 days. Some doctors may not be advisable, but you see to that how far you can do. And early mobilization and specific muscle training is very important to improve the functional conditions. So always the protocols, we should start from 45 degrees from the reclined positions. Joint contractures, muscle tone, all these things are important aspect in the ICU itself. And if the patient is already developing the contractures, or you feel that excess amount of spasticity or rigidity is there, use the splints so that you can maintain that position. But you see to that every time it is giving a rest period or remove that area to avoid the skin ulcers or skin lesions. Such things we need to take care. If the patient sedation score is less than -2, or if the patient's cooperation level is less than 3, then we should give this kind of protocols. We can give passive exercises. It is a protocol which is already given in many articles. We can give 5 times per joint for set 1 set, and frequency once in daily. We can give stretching, which is duration for 20 minutes. Passive cycling, you can give for 20 minutes. You can give for upper limbs as well as you can give for lower limbs. Electrical muscle stimulation, you can give for duration of 60 minutes. You can give continuous passive movements. Okay, 3 into 3 hours daily. That means you can give 3 hours in gap you can give. Splinting duration, whenever you give splints to the patient, every 2 hours you see to that you are removing that splint and giving a brief air circulation to that area. If the patient is conscious and able to follow your instructions, never go for any passive. As much as possible, make the patient to give active therapy. Whatever is the functional possibility if the patient is having, based on that you give functional training for the patients. To avoid the muscles atrophy and improve the muscle strength, you can use the FIT component, that is frequency, intensity, type and time, for the patients. And this is for the patient who is able to respond to you. That kind of patients only you can give this sort of active exercises. Making the patient to stand or sitting at the edge of the bed, this gives more of static or dynamic balance for the patient to come to the standing. And sitting from chair to stand, and 1 or 2 steps going front and back, these all are training for the walking mobility. So as I said, the patient is in ventilator also, we did all these activities. If the patient is conscious, able to respond, if the patient is in ventilator, all the parameters are stable, you can do all this kind of exercises to the patients. Continuous rotation therapy, I said, both sides you have to do alternatively. And this is the 4-in bed. Some of the hospitals having this type of beds. Otherwise, what we have to do is, we have to transfer the patient to the tilt table with all the monitors. Then you have to give tilting of the patient. Why? Because in some conditions, neurosurgical conditions or neurology patients, when they're coming for the recovery period, we give one of the main protocol which is called as coma stimulation. In coma stimulation, you know, vestibular is one of the component. For the vestibular component to improve, we need to facilitate the vestibular system. For that, rotations is required, tilting of the bed is required. Then only the patient will be able to balance their body against the gravity. So, but safety interventions we need to take care. We should monitor the parameters, how it is. Based on that, only we can give all this kind of treatments. And whenever we give the intervention, we should be knowing when we are going to stop that intervention. That is very important. Muscle, 48 hours of any mechanically ventilated patients, their muscle atrophy comes 20 to 30%. So even if we are normal, if we go to the ventilation, within 48 hours our muscles started getting wasted. So it is very important. So whenever we train the muscles, we need to train the respiratory muscles first, the upper part of the chest muscles and plus the neck muscles, because that will assist your breathing. So inspiratory muscle training is very important. Inspiratory muscle training is not only meant for respiratory group of patients, it is meant for the neuro patients too. Other exercises which we can do is resistive bands we can use is portable leg and ergometer, which is basically used to train the upper limb muscles and lower limb muscles. We can use the tilt bed. Most of the neurosurgical ICUs will have a tilt bed permanent there, so we can give stimulations to the patients. Other standing equipment which we don't have in India, but some hospitals they have it, and stand aid. These are the other things. So whenever we use the ergometer, if the patient is in ventilator, if the patient can move the lower limbs actively, we should give quadriceps force, because that is the one you are going to train for standing position. If the patient is able to stand, then only they can walk. For that, you know, gluteus muscles, your quadriceps muscles and your dorsiflexors are very much required. For such conditions, what you should do, in supine position or the patient is in the ICU itself, you should start improving their muscles. This is Arjo, which we are not using much in India. Airway secretion management, I think most of you know it. We can do hyperinflation for the patients. Drainage of endobrachial secretions, should be able to know how to do sections. Most of the times it is, people will think, especially physios will think it is the nurse's duty. It is not nurse's duty. If you are posted in the ICU, you should be knowing how to give the manual hyperinflation, how to do suctioning. When you do the suctioning, see to that there is no bleeding of the tracheal bleeding or any such things or oral bleeding happenings, because patient should not die with the tracheal bleeding. Sometimes it may unnoticed. So see to that suctioning you should be able to do properly. Whenever you give anything, see to that humidification is given to the patients prior to your treatment. So if the nurses are given at 12 o'clock, if you are going to treat at 1 o'clock, well and good. If the patient is got the humidification at 12 o'clock and you are going to treat at 3 o'clock, may not be beneficial. At least see to that within 1 or 1.5 hours you are able to give respiratory therapy after humidification. Suctioning, I said, mechanical inflation we can do. Other things which you mobilize or which you do positioning, automatically secretions will be coming out. Okay. Rib springing is the one. PNF and rib springing is indicated for all neurosurgical conditions without rib fractures and pneumothorax patients. If the patient is having a pneumothorax or fractured ribs, please don't try rib springing over there. But PNF stretching will facilitate the respiratory muscles, as well as rib springing also will help the patient to facilitate the respiratory muscles. So that is very important. This is one of the protocol which is published in Manival et al., one of the Indian author. These are the things they are given for all the patients in MICU and also neurosurgical patients. So when you see that protocol, you can see it is not only with your movements, it is starting with airway clearance. It is trying for how to improve the breathlessness to increase the relaxation therapy, which may not be indicated in neurological conditions. But you can see next one, functional capacity or ventilator liberation, how will you do it? The thing what we have, everything we know, but we don't know where to apply, where to stop it. Make sure that all the treatment things what you required for the therapy is nearby you. You should not leave the patient. Suppose if the patient is agitated, remove the patient's sling and go and take the pillow or something and go. By the time the patient would have pulled out everything. So whatever you need, assemble near the treatment area. Never leave the patients once the physiotherapy starts. Or you should have two people with you. Always see to that when you're treating the patients, the eustachian tube usually come out. See that it is there. Or tracheostomy tube usually comes out. So you also have an eye over there. Check the length and security all tubes. You are trying to rotate the patients. The catheter will come out, the bed will spoil. Or the IV lines comes out, it will spoil the patient's IV line also. So see to that all the drains and tubes are in secure place when you try to mobilize the patients. And always, as I said, heart rate, respiratory rate, BP, all the SpO2, all should be monitored throughout your thing. Whenever you make the patient to stand or sit, use gait belt. You must be knowing the gait belt, which is thick, which is having a width of so much, and which should be secured in your hand when you make the patient to stand or sit. Always, how to transfer to the wheelchair, how to go back, everything should be taught to the patient. Whenever you are trying to mobilize the patient in the ICU, you should have a full tank oxygen with you when you transport the patient, because anytime if anything lower, you have to pump back to the patient. Neuro ICU patients, mostly these are the things you can see. Either they would have in aplegia or paralysis or decerebrate or decorticate rigidity. Based upon that positioning, you should put the patient to the opposite pattern and make the muscles to be in a lengthened position. So if it is a flexed position or if it is a decorticate position is somewhat, we say it is a dangerous situation of the patient. So try to avoid the decorticate position into a flexion position such a way that the patient will not get more of extension synergy that you can avoid. Paralysis is some amount of voluntary movement is possible for the patients, so we can actively perform that movements. Plegia is complete, total inability. So maybe due to the cerebral cortex or pyramidal tracts, whatever it is. So based on that plegia, you have to treat the patients. This is one of the clinical pictures. Suppose if you get a spinal cord injury patients or if you have head injury patients, based on the reflex mechanism on the body, you can see that what is the reflex, what is the activity going to come up for the patient. So for example, plantar flexor, which indicates there is a brain insult. So for example, if there is a superficial reflex mechanism may show, if it is a spinal cord injury patients, where is the lesion, how it is recovering, all these things. Asia scale will look into it only by the anal reflex, that is different thing. But based upon the area where the lesion has happened, you can always plan for the treatment. Check whether it is a normal reflex or abnormal reflex. Sometimes when you try to ask the patient move, and the patient suddenly flex the limb, it may be due to a reflex stimulation on the plantar area. It may not be due to the normal movement. Such things you should be able to differentiate. This is the brain hemodynamics, blood flow usually. So whenever there is a cerebral blood flow, or when you say that perfusion rate, or when you say the blood flow to the brain is increased, usually this is how they calculated. It will be there in that CP monitor. But usually you see to that the pressure monitor shows to 60 to 95 mm of Hg. So that means your systolic pressure you should be able to calculate and say whether the patient's BP is increasing abnormally or whether it is going to decrease abnormally. So when there is a reduction, the patient may collapse. That is also a problem. When you increase also, it may increase the heart rate, which can cause myocardial infarction for the patients. So both way it is difficult for the patient to manage. So that is why we should know what is the brain hemodynamics. So that is why we say if it is more than 100 mm of Hg, we can maintain the patient. So if the patient's systolic pressure up to 100 is okay, we can manage. But if it is lower, then we should be careful because the patient can go for hypotension. So usually when you raise the patient to 15 for 45 degrees, if the peak is less than 10 mm of Hg, we say it is safer. But if it is abnormally increased, even 10 itself we say it is dangerous, but it should not be 10 or about 10. Okay, suppose 45 degrees you incline and should be more than 5, it should be between 5 to 10 mg, there is a difference, it's okay. But if it is more than that, it is not good for the patient's brain. So that is very important. So that's why we know cerebral blood flow is very important for the neurosurgical condition. So I'm not going to detailing of it, how to do it and all, because usually we'll have a mean arterial pressure where we'll calculate, or we'll have a cerebral monitoring system where we can see the blood flow. So as we say, the oxygen percentage, or usually we say, if you put the SpO2 machine in your finger, it should not be below 80. So any neurosurgical patients, either with the spinal cord or brain, you should not lower below 80. You should be able to maintain one position with the 80% of oxygen supply. So this is how we calculate, and we say it is 32%, 33% for adults, and with a range of variation from 25 to 42%. This is how we say the oxygen supply to the brain. This is one of the method we have used in many areas. It is not published in many papers, only 1 or 2 papers I have seen much into that. This is useful for the step-up procedure to ambulate the patient from lying down to walking. So if you get a neurosurgical patient, if there is no plegia or patient is going to improve by themselves, definitely we can use this protocol to improve the patient's functional mobility. So it is starting from head raising to 45 degrees, then sitting up to the chair 65 degrees, then sitting at the edge of the bed, then turning and coming into the chair, then transfer standing and bed to the chair. Usually we give the respirate. We say meal time means, your meal time is usually 3 to 4 hours gap. So that's why we say coming for the meal. And inside the room, how much to be think? It should be only 20 feet, we say. Then you can improve to 50 feet, then you can improve to 100 feet, then 150, like that we should improve. So that is how their lung capacity and the general musculatures will improve. So only thing, if there is a hemodynamic instability, that means the variations are coming, or if there is a subarachnoid hemorrhage, or if the ICP is not maintaining, in such conditions we cannot use, because there are the other comorbidities we can say with the neurosurgical conditions. It is difficult for us to use this protocol. So this is usually the predictors for the any ICU conditions. One is age. So as you know, we say youngsters will improve fast. If there is a medical comorbidities, that means if patient is having a diabetic neuropathy or diabetic mellitus, or patient is a hypertensive patient, there is a variation in your protocol. There is a frailty, lot of osteoporosis or something, then, or weakness of muscles. Level of independence in the admission of the patient. Hyperglycemia is also one of the related things. It doesn't mean that all these patients will go for bad situation, but these are some of the things when they have, we need to be more careful. Thank you. I was rushing, I think I was being late, so that's it. Thank you.
Good afternoon. It was an excellent session by Dr. Ani Thomas ma'am by explaining the procedures, what we do in ICU, and all the precautions, especially assessment. I'm the person who supervises 12 ICUs in a day, and so I felt she clearly explained the assessment and what are the complications, what we face, and how do we take care of the patients in ICUs, what are the steps to be taken before doing physiotherapy. Thank you, ma'am. It was a wonderful session. I'm so enlightened to chair this session. Thank you, ma'am.
Thank you. Thank you, ma'am.
Good afternoon, Dr. Annie, ma'am. Again, it was a very informative session on neurosurgical ICU management. I think you have covered each and every corner of the topic in detail and in a simple way. You started from what is ICU, and you have mentioned about the teamwork in the ICU and even the ICF, importance of the ICF assessment in ICU, about the ventilator dependency and all. And I'm sure that it is very beneficial for all of us. And thank you, ma'am, for such an informative session. Thank you.
Thank you, ma'am.
Thank you, ma'am, for such a great session. Thank you, chairpersons, for concluding the session. It's time to hand over the memento to the scientific session speaker, Dr. Annie Thomas ma'am. I invite Professor Manju Krishnan ma'am and Dr. Jayashree ma'am to hand over the memento. Inviting you ma'am to the stage. Attention everyone. Guess the round session is held at 12 p.m. Anyone interested can report at venue 2. Anatomy Pictionary is held at 1 p.m. Anyone interested can report at 12:45 p.m. at first floor of JDT Islam College of Physiotherapy. Guess the round session is held at 12 p.m. Anyone interested can report at venue 2. And Anatomy Pictionary is held at 1 p.m. Anyone interested can report at 12:45 p.m. at first floor of JDT Islam College of Physiotherapy. Thank you. Attention everyone, next session is going to start.
Leading towards the next session, the two chairpersons for this session are Professor Andrews Milton, the principal of Bethany Navajeevan College, and Chinju Alvin from Limsa College of Physiotherapy. The session will be addressed by our speaker, Dr. Shanmugananda E., the professor of Mahatma Gandhi College of Physiotherapy, Pondicherry. He would like to empower us on the topic intellectual property rights and design thinking. So please.
Good afternoon to one and all. Myself, Professor Dr. Shanmuganand, Head of Physiotherapy from Sri Balaji Vidyapith, Puducherry. My topic is intellectual property rights and design thinking. The main objective of this presentation is to make and create awareness about the intellectual property and what is intellectual property rights and what is design thinking among young chaps. Actually, this is designed for young chaps only, but only limited numbers were here. But at least I want to concentrate you numbers here. So please concentrate in this. Okay. How this topic and what is the need and importance of the topic is and why I have to present this in this presentation means logically I am ambassador of Institutional Innovative Council and this is under Ministry of Health. So there is a policy for the nation that is to improve the economy. If they want to improve the economy means definitely they have to make some policy, right? So our GDP also will be increasing so that the national growth also will be increasing. And the responsibilities and roles is among the youngsters like you only. So don't think that we are physios, what we are going to do here. Definitely not only physios, any professions can think they can design or they can make any product and they can market in our respective field itself, okay? So just understand about this concept. Okay, what is intellectual property? The property which protects some creations or inventions. Some creations or inventions, whatever we are doing, it is protectable. Otherwise, it will be infringed by some other else. For example, we can think anything. We will be having a lot of ideas, isn't it? We can make or we can get any ideas. So whenever we can get ideas, what we will think? We'll try to draw it. We can make some pictures, some drawings. Then after that, we can try to make some prototype. Like something in a wood or in papers or cardboard, whatever you can make some prototypes. So from that onwards, our product will start to marketize. Okay, so here, what I want to make is, generally we'll be thinking while seeing the bus or while seeing the cycle, what we'll be thinking, see, this is the cycle. If the cycle is modified like this means, it will be good for us. It will be more feasible for us also to travel. Like that we'll be thinking. So like that, lot of concepts we'll be having in our mind. So what we are doing is we are losing all these concepts. Actually in China, 15 years back, they have made a policy. That is like in India, they also made some national education policy. So this policy came before 15 years. So during the time, they have made lot of skill-based programs in the schoolings itself. So due to that, what happens in the schoolings, these students like us, they have made all those ideas into design and that after that, they have made into a prototype. And then again, the nation have brought some agencies to bring all the prototypes and they have made it materialized. After that, they have make it in the marketing. So now, because of that, whatever product we are seeing is made in China, made in China, made in China. All these made in China concepts start from the schoolhood only, not like other entrepreneurs. All the entrepreneurs from our side only. Okay, if you are taking a handbag or if you are taking any mobile gadgets, everything is made in China. Why? Because the nation policy is like that. So that only now we have waked up and now our government also have think like, okay, we also have to make all the things from the schooling itself. So that only in national education policy they have kept lot of skill-based programs, right? Okay, so if intellectual property, suppose if you are thinking anything, some ideas, or if you are designing some things, or if you are writing some things, so in which category it is protected? Because of course it should be protectable. If it is not protected, it means someone will take the advantage of that, okay? 4 types, these intellectual property can be protected. The 4 types are, one is patent, the other one is copyright, the other one is trademark, and the 4th one is registered design. Let's see one by one. Generally patent, this patent, patent means something, it should be a product. Some technology has to be there. It should work. That means we have to say that this is made up of, this is used for, and this will be function like that, like this. Like this, we have to make some prototype. So if you are having some innovative prototype means, we have to register it for the patency, so that it is protectable. Otherwise, by seeing your product, somebody will take the advantage and he will register it and he will gain all those things. In next slides, I will tell about few examples regarding this, okay? So few examples for the patent means, for example, you know very well these mobile phones or toothbrush or sunglass, these are patentable, okay? Copyrights. Copyrights generally this art, literature, poems, drawings, or singing songs. Even you people are taking some videography, some documentaries. So these documentaries, these are all copyrighted version. You can get copyright for these things also. Suppose if you are making some innovation and if you are doing something and if you are uploading in the YouTube, some people will understand or like your concept, and without a willingness or without your knowledge, they will make it in the movies and they will sell it. But the thing is, you will not get even an acknowledgement. So that only we have to do whatever we are thinking, whatever our innovation is there, we have to try to get a copyright or patent. The third category is registered design. Registered design is nothing else. So again, I am coming to the point. If you are thinking, for example, if you are seeing any water bottle, do you think this water bottle is very big so that I cannot able to carry it in my bag? So, I think the conference bag today, very nice petty conference bag they have given. So this is somehow looking catchy. And in this, your water bottle have to, means hold in that means, so that it can be useful for you. Also, you can take it to the colleges also. Not only the laptops, again the water bottle also, you can put it along with that. But in market, such kind of water bottle is not available means, so what you can do? You can design it. You can draw it. So this is the bag shape. So if the water bottle come under this category, so it will be hold in the bag also, so it will be useful for us also like that. If you are thinking like that means, again, this thing also is, you can register. This design is registerable. What you are drawing, that design is registerable. So suppose if some companies are liking it, they will see what are the things are registered. So if any companies like, okay, this drawing, this is good, so we can materialize, we can sell it. So then what they will do means, they will come and they will approach to you. So that you will be getting some advantage, some financial benefits. So like that also we can make some benefits through this registering the registered design. I think you can see in this pic, what this means? Toothbrush. This is the electrical toothbrush it is. So we have shown that what is patent, what is registered design, and what is trademark, and what is copyright. Trademark I didn't come, trademark I will come to the last. And what is copyright? The look, appearance, suppose if you are making some toothbrush on your own idea, if you are creating something, and if you are registering, that means this registered design. In ancient hood, you can understand that how this toothbrush has been modified. By the time we are using the sticks only. Then after that what happens, in one day they have just crushed it and they have made it like a brush. Then after that in stick form it came. Then after that in flexible it came. Then after that when people have kept one cover in the toothbrush, and for that also they have got some patency. So if you are drawing means, that will come under the registered design. If you are making as a product means, that will come under the patency. Okay. So you can see the design is, the appearance you can get for the registered design. The technology, how this toothbrush is functioning, that will come for the patency. And the advertisement, that lot of Colgate or Pepsodent or this Oral-B advertisement is coming. Na? So these things will come as a copyright. So the brand name, that is trademark. Brand name is, you know very well, lot of brands are there. What we are wearing, the clothes or foodie like KFC, or biryani stalls like Talapakati Biryani. So these are all the trademarks, the names, the brand is a trademark. Of course, for that also we have to register it. Otherwise, someone will claim the infringement. I think a few examples I'm having for this also. I think, hope that you have understood what is intellectual property right now, okay? And dear students, attention to dear students. So this is not only lecture session. The last 5 minutes, I'm going to come over there. Some task is there. With the means moderator's permission, I will conduct some 5 minutes workshop. Okay. So pay attention. Definitely, I'll be coming here. Okay. So now you are having the idea about the intellectual property. So what is intellectual property? That is a property which is protecting patent, copyright, registered design, and trademark. Okay. In patent, which I have told already. So that should be some technology, it should be materialized, it should be a product, so that we can get the patency. Usually this patency will last for 20 years. Till 20 years we can have that rights for us. And the inventions will be kept confidential to them who is applying for this patency. Okay, this picture, what you seeing? Anyone can observe here? Okay, someone is observing here. So you can see that the next one, the line indicator, speed sensor. So these things also will be having some patency because previously this technology we doesn't use. But nowadays in last 15 years only this kind of technology we are using in our Indian roads. Okay, so this has a patency. So this is the one of the example. And in this room some patent products are there. Can you see this image? What are the patent products are there? For what and all they might get the patent in this? One is television. Anything more than television is there? If yes means just raise your hand, I will not ask the questions. Other than TV, any other is patentable? If yes means raise your hand, I won't ask question. At least raise your hand. Because it is very, only less numbers is there. At least try to, I am attracting your concentration towards here. Fine. See, you can see the night lamps. You can see the phone. You can see some sunglass. These are all the patent. Even the curtain rails, that is also a patency. So like this, toys, TV brackets, sunglass, curtain trackings, even the night lamps. So such kind of patent products are there. In the wall, some designs are there. That is registered design. And pillow covers, registered design. Okay, suppose a few example. If anyone using our technology even after registering means, definitely we can file, we can go to the court and we can take our rights for what we are having. Because your rights is saved, protected for 20 years. Definitely no one, without your permission, without your knowledge, no one can use the technology or no one can modify the technology also, so that you can file a case and you can get back your rights. Your rights is not only your rights, and also it is going to be somewhat financial benefit, or your status will be improving regarding that. Yeah, anyone know about this turmeric battle? This turmeric battle, anyone heard? For turmeric, we have fought along with the US for so long years, because turmeric is our conventional, that is our native product. Very, very long years we are using as a native for herbals, for medicines, we are using the turmeric. But what this US people done, they have taken the patent in their own nation, and for all the turmeric products, they have asked us to get their permission. It was so difficult for us, knowing, because it is not, it is unjustified, because it is our native product. Turmeric is nowhere labeled or nowhere related with the US. But the thing is, whatever turmeric products we want to use, we have to get the permission from the US before. And now, after a week, now we have filed and we have fought back our own turmeric patent in our control. So there is no rights with the US. So whatever turmeric product we are doing, that we can do it conventionally among ourselves. So like that. So dual SIM battle. Have you seen this mobile phone, dual SIM mobile phone? Of course, without dual SIM mobile phone, no phone is there available right now. The interesting one is, previously, this technology is innovated by our students, to engineering students from Trichy in Tamil Nadu only. So the Samsung company came forward, and after observing this technology, they have proceeded with them. Please give this technology to us and we will pay for you around 30 paise per product, like that. But these people, first they have accepted, and after that, one of that friend, he told that don't accept for this 30 rupees or 40 rupees. Instead of that, you ask with a mobile phone some commissions like that. So unexpectedly, this fellow have asked us some 10 to 15%, I think. And it was shocked by the Samsung company. Then they told, no, we don't want this technology. We will have our own technology itself. Then what they have done, in US, they have pre-registered. Because such kind of things, I should not use some words. They have pre-registered. They have showed like that. That means this dual SIM technology has been registered very long years back. Like that, they have shown. Then after that, what happens? They started to produce it, manufacture it. But this friend, what? They didn't have any copyrights. They didn't have any patency. So they didn't register the design also. So unluckily, they have lost their acknowledgement in that. Otherwise, think about the status. Without a dual SIM, no phones is available right now. If he could have got some agreement by that time, so he could have been a millionaire by this year. Okay, so like that, your ideas or innovations has to be cooperated. Definitely, this will be helping you financially also. Okay, trademark, I think I'm not that much concentrated today because trademark is something important with creating a brand only. In our field, creating brand means hospital sectors, otherwise rehabilitation centers. For example, Adit Rehabilitation Center. It is very familiar means so that if a neighbor towns or neighbor cities, some other people using this familiarization, he also will keep on board Adit Rehab Center. Only because of that, without his knowledge, he will keep the board what the people will be thinking, patients will be thinking. They'll be thinking this is the same rehabilitation center. It is already familiarized. So they will start going there. So without his knowledge or without his intention, definitely it will be an injustification only for him. So that what we have to do is, we have to register our brand. Okay, so that is called trademark. So in these cupboards, few things are there. Any known products you are able to see in this? Any known products? You can see one in the ground. The bottom thing you can see the surf. From the bottom to the third you can see the tide. So these are the famous trademarks, isn't it? Infringement. What is trademark infringement? You can see the original McDonald's. In many areas, this infringement is happening. Instead of this logo, you can see the another logo and they will name it as a McDoubles. But for the population, what they will think? Okay, this is McDonald's. Like that they will think and they will go inside. Only 60% know about the logo, about the thing. But the remaining 40, leave the 40. At least 20%, without this awareness, they will go. So this is infringement, trademark infringement. So that only we have to be aware always. Then we can file a case against these people. So like that, in copyright also this infringement will happen. Do you know him, this person? Anyone from that side? Anyone knows about him? He is our famous musician, Ilayaraja. There was one story. Again, I think around 5 to 6 years back, there was a call from famous mobile network company to him. The song was playing. After playing, there was a pre-recorded call. Sir, if you want to keep it as our caller tone, you have to pay around ₹30 to set. Like that, one call is coming. So he got irritated because that is his own music, that is his tune. Then only he came to understand that people are marketing his own music without his attention or without his knowledge. And he understood how much of money has been transacted due to this. The mobile network company is nowhere related with his music, but how they are earning without his acknowledgement. So what he done is he registered a case. He registered the case, and the Madras High Court on Tuesday related that they have been announced that a special moral rights for 4,500 songs composed by him for more than 1,000 movies in his career, spanning over the 4 decades. So this is might be thinking that nowhere we were related, but you live about this music, but your drawings are there. Today you are taking a lot of pictures from the Google images for your presentations, isn't it? Many of them I have saw that. Even those pictures are copyrighted. And the thing is, without the concerned person, you cannot use that pictures also for your presentation. If like that, if you are using means, definitely it is infringement only, okay? So here we have to pay an attention, otherwise at least we have to get an opinion from those to use their photos like that. All the photos like this are not copyrighted. Only few photos are there that is copyrighted, which you can able to see in that itself. So registered design. So here I have kept some bottles. The innovators, what they think is in various shapes and various sizes, they have drawn something and that drawing has been materialized. So like this, even a water bottle also you can design like this. Even, now leave about the water bottle, even if you want to modify the chair, you can do it. Even if you modify the cushions, you can do it. For that also we can get the patency. Before that we can get the registered design for it. So like this, we have to utilize all those things here. So, registered design. What is this? Something this is like in travels we'll be using like this, isn't it? But this kind of models is unfamiliar for us. The thing is, for the cars or lower vehicles, so it will be convenient for them also. So what they are sketched, this is a drawing. This is just only a drawing. Even this drawing is registerable. You can register this design. And once, if you are approaching any companies, if they are interested on your technology, so sorry, in your design, they can use it. So you will be getting some acknowledgement. Okay. So like that, we can, whatever is there is in our mind, we can draw it and we can make it as a productivity like that. Okay. So some more examples I want to take it here itself. So what I'm going to do is, with the moderator permission, I'm going to come over there right now itself. I think everybody is having some pen, isn't it? Everybody having the pen and any papers? Pen or paper? Is there? Okay. Take your pen and paper. Everyone take your pen and paper, please. From that crowd, everyone take a pen and paper. Take a pen or paper. Sir, can you give 5 minutes so that I can go there? Working? Working? Okay. Have you took? Have you took a pen and paper? Everyone. For our students, it is new. It's already old. Okay. The task is, I think, which is easy for you, drawing the wallet or drawing the handbags? Boys, make a wallet. Girls, draw a handbag. Individually, you should not copy it. Okay? Individually, I am giving 1 minute time. In that 1 minute time, you have to draw a wallet. Otherwise, you have to draw a handbags. Okay? 1 minute time. Attention to the group, please. Take. No empty hands I didn't like. Take a paper. These people started. Good. What about here? Paper illa. Where it is? Handbags. Okay. 1 minute time. Time starts. Please. Boys, for you task is wallet, and for girls, it is handbag. So in this, what you have to do is, you have to draw it, you have to say about that purpose and advantages and materials. Materials, anything, leather or resin. Sir, it is flexible, sir, it is not flexible, sir, like that, something you write. It should be your own thing, your own idea only. Whatever it is, doesn't matter. Okay? "30 seconds more. "20 seconds. I'm going to Good. So this group is doing sincerely. Handbags, any design. Okay, shall I see it? Wow, super, great. Yours? Fantastic. Great. Good. Okay. Okay. Fine. Okay. What about that group? So handbags. Yeah, now itself I got some good designs with technology. So good designs I got from the handbags. What about the wallet? Wallet. What technology it is? Flexible one. Leather one. Okay. What about here? Great. Good. Very good. Very good. Okay. So I think, hope you understood. And designs are made like this only. No need to, if you are understanding, if you are having some concepts in your mind means, this is the first way that how you have to bring it in the paper. Okay? As a picture, as a diagram, as a drawing, as specifications. This is the first stage. You can register this for the design. Okay? So this is the first way. Before materializing, we have to register our design. So now, to make it in a better way, the second task is, you just discuss with your friends. Group wise, that group, you discuss with your friend, all together, you give me only one example of the product, common product. You are having various ideas and various thoughts. So in your own way, you have made it. Now what I'm saying is, you discuss among yourself about each individual ideas and you make it as a one. Okay, so what are the best things are there, you collect it as a one and you make it in the single presentation. Okay, single diagram I have to bring it. Okay, discuss among yourself. So 2 minutes is there for you. Task is 2 minutes. The best one you have to take it and discuss. Very good, they have start discussion. Here, start discussing. Okay? The task completed. So just bring one from this crowd. Anyone bring yours. The common maid. Come here, come here. It's okay, not an issue. Whatever completed, you can bring it here. Okay, similarly from the valet and from that group, please, anyone bring it here. Okay, good. Your name?
I am Ginny Paul from Limsar Angabali, second year MPT student.
Can you explain about these specifications and about these bags and its
This bag has a golden chain, shoulder adjustable chain, and it is available in different sizes and shapes. It is having a small pockets and it's very user friendly and spacious. It has small white pearls hanging and white feathers hanging in it, and all colors are available.
Excellent. Give a round of applause to her.
Myself, Princy Kea, working as physiotherapist at CDMRP under University of Calicut. I have designed this purse as a disabled friendly. So here I have put a shoulder cuff. So there will not be, because of the shoulder cuff, most of the ladies are complaining of shoulder pain. So I have designed a shoulder cuff. It is length adjustable also. Then I maintained a sling there. So if a disabled person, they can hang it over anywhere. A sling is there, height adjustable sling. Then a handcuff also. We know that more time we hang it, we will have CTS like difficulties. So I have managed a handcuff there. It is also length adjustable. And this zip, instead of zip, I have made a metal buckle. So the disabled persons, those who have arm disability, dysfunctions, motor impairments, they can easily access that. Then I have made a side zips for phone and a umbrella pouch, so they can easily get it. Instead of opening the zip, they can easily get it from the sideways, or anyone can help them. Because it will, if we are trying to help them, it will affect their privacy. Because inside whatever materials we don't know. If side zip is there, we can help them. Anyone can help them. And the height is adjustable as laptop height. There is a USB port. So instead of charging it from taking outside the lab, we can charge it from outside also. The material will be made of waterproof and lightweight. So everyone can access it. There I have made a comfortable small wheel for that. Because if disabled students, they cannot hang it, they can simply draw it. So, thank you.
Very good, very good. Thank you, both of you. Bus, the aim is finished. Very beautifully, you can see, very beautifully they have drawn. So all these things are having some specifications and all these things having some innovatives. The thing is, such kind of innovative things, some ideas we are keeping in our mind itself, isn't it? So there is no vision or policy for the nation to bring all those things. So some center point is needed to bring all those things. Just now they have waked up and they are just motivating all the kids like you, and they are trying to make something so that only the Make India concept begin like that only. If Make in India is not happening, our GDP will not progress. Okay, the Make India concept is rely on with made in China only. Okay, so the policy is better right now, and think we are having the very good future through you, and definitely it will be good for us also. Thank you both. So we will see you there. Thank you. See, Very simple. It is very simple. Just 2 minutes it takes time for us to use our brain. Very neatly, very fantastically, you have put all your thoughts, your innovative ideas into that. When you join in a group, all the things has been materialized, isn't it? This is not only for the leather bags or handbags. Lot of physiotherapy items are there. Lot of physiotherapy modifications are there. Without our knowledge, some other people like biomedical engineering wala or some other engineer fellow, they are taking our advantages without knowing you itself. Actually, we have to do all those things, modifications. And so that only I have requested Sajeevan sir also to keep some prototype innovation category in this conference. Because we have to motivate our students to bring your innovations to the common platform. So then only everybody will understand, okay, why we cannot do like that. So there is a hope for us also of creating like you, the young chaps, in innovating many, many more products like that, okay? So this is the aim of my conference title. I think it worked out. So how this picture has been materialized, definitely one day such kind of innovative ideas also can be materialized, okay? So under registered design it is coming. So this is the picture and how it is brought out. So here, copyright, patent, registered design, trademark, everything is there. If I want to ask question means I can ask, but I hope that you have understood already. So definitely this makes me to be happy, at least some few students have got the knowledge through this presentation. Okay, I'm ending my presentation. Thank you. Any doubts? Any doubts? What is patent? What is design? What is copyright? What is trademark? Why we have to understand this topic? So how to think, how to create an idea, how to make us a design, means how to draw it, how to bring the design, how to materialize it. Okay, the last one is marketing. That we no need to concentrate here. That automatically the innovators will come and approach you. Entrepreneurs will come and approach you. Shall I end my session? Thank you.
Thank you, Dr. Shanmuganan, sir. It was a very excellent presentation. Actually, sir was giving a good outline about the intellectual property rights, that is your patent, copyrights, and trademark, and registered designs. Usually, we physiotherapists more oriented only on the treatment aspects. This is the another area. There is a large of scope because as sir mentioned, the Make in India concept. It is not only about the country, it also about the economical development of the individual physical therapist or anyone who invents the product. So as a physio students, I think this talk, this presentation might have inspired you. Maybe very few people are here, but though this is an excellent opportunity, other people are missing. So now itself you can have a vision to produce some prototype or any kind of technical inventions so that you can be a very economically sound individual also. So thank you, sir. Thank you for the wonderful presentation.
Thank you, sir. Thank you.
Thank you, sir. Thank you so much for this informative session. As sir said, this is a topic which is very less discussed among people. Not many of them know about this. I'm not sure if all the physiotherapists knows about it. So, and you also gave them an opportunity to be interactive and innovative. You gave them an opportunity. They tried to draw something. So they actually got an opportunity to be innovative. So that was indeed a good session, sir. Thank you so much.
Thank you, thank you. The final thing, if anyone is having such kind of ideas and if you are having any doubts or want to register like this means, you can approach us. We are having the cell in our institute, so through that we can help you always. Thank you.
Thank you.
Thank you so much, sir, for this great session. Thank you, chairpersons, for concluding this session. Now I request our principal, Sajeevan sir, and the chairpersons to hand over the memento to the scientific session speaker. Thank you, sir. Let's move forward to our next session. The two chairpersons for this session are Anup sir, the professor of EMS College of Physiotherapy, and Nandakumar sir from EMS College of Physiotherapy. Our next session will be commenced by our resource person, Dr. Vel Murugan, the principal of Shanmuga College of Physiotherapy. He has completed his bachelor's and master's in neurology from Dr. MGR University in 2008. He has been part of various institutions including Mahatma Gandhi Medical College and Research Institution, Bethany Navajivan College, and Sudha Hospital, Vadalur. He has been a great mentor and empowered and enlightened many students. He would acknowledge us on the topic impact of virtual reality on neurological conditions. Sir, please.
Good afternoon to one and all. Myself, Vel Murugan. I am the professor cum principal of Shanmuga College of Physiotherapy, Karaikal. First of all, I would like to thank principal of JDT College, Dr. Sajivan, for giving me this great opportunity to share my knowledge. And thank you for introducing here. And for the chairpersons also, thank you, sir, for sharing my session. Okay, let me enter into the session. Now I am going to share my knowledge regarding this virtual reality. The topic is on impact of virtual reality in improving neurological conditions. Okay. So I hope everyone knows this definition of VR. So it is an interactive simulations where the presenters are going to interact with the environment, artificial environment. And this technology has gained a recognition as a useful tool for cognitive research, evaluation, and rehabilitation purposes also. Before this, one thing I want to tell this, virtual reality was established in the year around 1984 itself. First, they have introduced in the Navy and even in surgery purpose, they have tried like trial and error. Then only they have done it as a recreation like gamings. And for education purpose also, they have introduced it. Let me tell about the types of virtual reality. There are three types are there, like immersive, semi-immersive, and non-immersive. So non-immersive is the sense, I hope these 90 kids, they would have been well versed in this non-immersive virtual reality. In those days, we used to play games in systems. So exactly that is the non-immersive virtual reality. Semi-immersive is a little bit variation from the non-immersive. We will be having some control over the devices and we will be seeing our own images in that devices. Immersive, it is fully immersed where we will be having a head-mounted devices and additional equipment may include like gesture sensing gloves, vans, vibrotactile platforms and multi-directional treadmills. These are some of the website link. If you want to just note it, you can just see some videos of non-immersive, immersive. Actually, this is my one of the training session. This is semi-immersive, and he is the stroke patient. See, they will be looking after the images which is displayed in the system. Okay, whenever they are moving their legs, the toys will be moving like whatever movements they are doing, the same picture will be copied, and through a sensor, the images will be copied and it will be reflecting in the screen. This is typically a semi-immersive virtual reality. This is also, see, he is also a stroke patient. See how he is interacting, he is playing tennis, okay. Somehow we want to make the patients physically active and we want to make them independent. Okay. So basically we used to give the traditional therapy like movements, passive movements, active movements, and task-oriented approaches. Of course, this is also a task-oriented approaches, but still they will be actively involved in such entertainment. This is also a stroke patient. So how he is moving his upper limb just. Also there is some trick movements are there, but initially we have to allow that. We need some movements initially. Main goal of this virtual reality is to cope up with their motor impairment. So we all know that in neurology conditions, there will be motor impairment. This is the first impairment, okay. And so it is going to play an impact in the physical function. So in order to improve this motor impairment and to regain the ability of performing activities of daily living, this VR is going to be the future of physiotherapists. These are the graphical representation. What happens when we give this VR? The left side is RTMS. This is repetitive transcranial magnetic stimulation. So what happens there? This cortical excitability controlled by balance of excitatory and inhibitory neurotransmission occurs. So thereby finally there will be an excitability within the lesion hemisphere will take place. Whereas in VR, intensive, repetitive and task-oriented training we are giving. So final result will be a reward-based movement training, actual motor performance will happen. So since there is lack of time, I am rushing. So these are a few conditions which I have included here. Apart from this also, we can give VR like Parkinsonism, multiple sclerosis, chronic pain management, autism, attention deficit disorder, developmental delay, and stroke. So uses in physical therapy. So it provides an interactive, motivating atmosphere where intensity and positive feedback can be controlled while retraining the movement. And it also allows the patient to participate in experiences that are both pleasing and rewarding. And patient and therapist are able to interact with a multisensory dimension environment that is explored in real time. So what are the benefits? It offers patients repetitive practice of functional tasks, and novelty of VR may improve adherence to repetitive practices. So we know that neuroplasty, repeated, what is this engram? 1000 repetition makes 1 engram. So for that we need this repetitive practice. Then this VR hardware and software have become less expensive and can be easily set up in any practices setting. Students those are doing research are going to do some research. This is my kind request. Please concentrate on this VR, which is going to be the future physiotherapy. So of course I have mentioned here less expensive, but still it is not there. We have to do much work over this area. Limitations of this VR in the sense, practice in virtual environments is different from physically practicing on the functional task. This is one of the limitations. And why should these rehabilitation researchers be interested in VR? So it provides a means for individuals with disability to pursue and interact with objects in a non-physical world. At the same time, its current applications include movement training, exploration of accessible environments, manipulation of virtual workplaces, assessment of mobility, and cognitive functions also. And also practicing in operating a virtual wheelchair or mobile robot, treatment of phobias, and also behavior modification purpose. This is also the same thing. It can provide a safe and consistent means of assessing and improving a wide variety of functional and cognitive abilities. At the same time, it can be tailored to an individual's changing needs, preferences, and abilities. So it depends upon the patient needs, we can give these things, or we can set up, we can customize this. We should also do, we should customize according to the patient need, and then only we'll be getting a better result for these things. Where VR applications using a head-mounted display can provide an immersive visual environment that focuses the user's attention on the program task and can offer a unique viewing perspective which provides enhanced feedback. So this is also one of the graphical representation. What are the benefits of this virtual reality in the medical field? So mainly, at the end, see at the bottom, I have given that motivate and entertain the patient. This is one of the things which I have seen. And it also improves the communication. It improves the accuracy of the movements, and it also reduces surgical time. It reduces the errors, and it improves the safety of the patient. It reduces the training cost, increase confidence level in the patient. It stores the patient data digitally, and also it restores the it gives a restoration of a patient. This is also one of the graphical representation how to implement these virtual reality. Okay, so we know this uh, sensory re-education. Okay, and same like that, this is one protocol is there, like we have to design the stage, modeling stage, programming stage, and testing stage. This is purely for stroke patients. So if you are giving this VR in stroke patients, it is going to improve the balance, it is going to improve the gait, and it also reduces the fall of risk of fall. Okay. And as I told you that there will be a motor impairment in the neurological conditions. So we have to mainly focus on this motor impairment, which is going to improve this coordination of the arm and shoulder movement, thumb and index movement, wrist and arm movement, isolated finger movement, hand opening, bimanual approach, and body balance. So these videos represents the tele-rehabilitation. Even in tele-rehabilitation also we can do this VR. And some of the neurological conditions like balance training. Okay, so even the concept is same. Even we have whatever we are doing in traditional, we are going to do it in virtual mode. VR simulations can be used to provide balance training exercise that mimic real life scenarios such as walking on uneven surfaces or stepping over the obstacles. And weight shift exercise also can be given for as a progression of this balance training. Then for upper limb rehabilitation, like reach and grasp exercise. These are nowadays we are using in rehabilitation purposes. The patient is instructed to reach and grasp the virtual objects which are displayed on the screen using their affected arm. The difficulty of the exercise can be adjusted by changing the size and shape of the objects and the speed of the movement, or by adding visual or auditory cues. Cognitive rehabilitation. Of course, in this area, we have only less research. Cognitive rehabilitation using virtual reality is a growing field that aims to improve cognitive function and promote neuroplasticity in individuals with neurological injuries or disorders. Virtual reality simulations can provide a safe and controlled environment for cognitive rehabilitation exercise, allowing for customized and engaging interventions that are tailored to the individual needs. Then cognitive rehabilitation, as we know that we used to this MMMC, mini mental state examination. Okay, whatever we are going to do that, again we are going to give us training, like attention training, memory training, executing the function training, and visual spatial training. Same, attention. Few videos will be displayed on the screen, and they have to, without distracting the audio voice, they have to attend that, or they have to identify through visual or auditory stimuli. Okay, this is how we have to give the attention training. The patient is instructed to focus on and respond to specific visual or auditory stimuli while ignoring the distractions. And if you want to do progression, you can change the frequency of the stimulus. Okay, or you can give some complexity of the task. Then memory training. Memory training also, so we have to show some pictures, or we have to mention some words. They have to memorize that, and they have to recall it, and you have to manipulate the information which is presented in a virtual environment. For example, they may be asked to remember a sequence of objects or navigate through a virtual maze while remembering specific locations. Then how to train this executing function training. So simple, like they have to think, reason. Okay, how will you improve this cognitive function? What is cognitive function? It is a task of thinking and reasoning capacity. So we have to add some activities. They have to plan, and they have to problem solve, and they have to take some decision making. These skills should be involved, and we have to make some virtual like that, and we have to do some, give some task, and we have to train this executive function training also. And visual spatial training, we have to place some objects in front of them, and they have to observe that, and they have to change those objects, and again they have to recall that, and they have to place it in a correct position. So this virtual cognitive rehabilitation using VR can be an effective and engaging way to promote neuroplasticity and improve cognitive function in individuals with neurological injuries and disorders. But still, there is a lack in this area. So we have to do more researches on this cognitive rehabilitation by using VR. And I have mentioned these musculoskeletal injuries, even though it is not in my content. I want to mention you like pain management, because in neuro conditions also we are having pain. It may be a chronic pain. So how to reduce that pain through VR? So we have to distract the patients from pain during rehabilitation exercise by reducing the need for pain medication, especially for patients with chronic pain. And patients like chronic stroke, they will be having like shoulder pain, hip pain due to muscle stiffness or muscle spasm, okay, whatever may be the reason. So they will be having chronic pain. So we have to distract them, and we have to make them involvement in such activities. By that distraction only,
they will be, of course there will be some effect, but it is not a placebo effect, In virtual reality simulations for pain distraction, patients are immersed in a virtual environment that is designed to engage the distracting. Mainly, we have to distract the pain concept. And how it works. Patients often experience an intense pain during rehabilitation exercise, which can limit their ability to perform the exercise effectively. But we have to incorporate this cognitive behavioral therapy program, and therefore improving how the individual pursues their pain and their coping strategies. Because it's cognitive behavioral therapy, there are a lot of steps are there. Okay, it depends upon the patient need, and we have to do a proper assessment, and after that we have to make a protocol for those patients how to do this cognitive behavioral therapy. Anyway, our idea or our aim is to distract the pain concept from the patient. Then even in exercise therapy also we can implement this virtual reality simulation, same like upper limb movement, like fingers, okay. In upper limb rehabilitation, patients can use these VR stimulations to perform exercise that target specific muscle groups such as reaching, grasping, and manipulation tasks. In functional movement training, these patients can use these VR stimulations to practice movements that mimic the activities of daily living, such as getting up from a chair, climbing stairs, or reaching for an object. See, the first picture shows that experimental setup of the immersive virtual reality group, and the second thing shows that non-immersive virtual reality group. Then, these virtual stimulations can be customized to suit individual patient needs and preferences, and can be adjusted to provide varying levels of difficulty to the challenges and motivate the patients. In addition, VR can provide real-time feedback on patient performance, allowing therapists to adjust the exercise program as needed to optimize patient outcomes. Because we are having some data in those things. For example, if you are asking a patient to keep some 800 steps within 10 minutes, this data will be coming over the screen, and they will be motivating themselves. Then studies have shown that VR stimulations can be effective in providing exercise therapy for a range of conditions, like improving the range of motions, including stroke, traumatic brain injury, Parkinson's disease, and multiple sclerosis. This is the same thing. Then, conclusion. According to me, this virtual reality, it is going to do a high impact in our physiotherapy field. I'm sure in that, in future, this is going to be the scope of our physiotherapists. By providing an immersive and engaging therapy experience, virtual simulations can improve patient engagement and compliance with therapy protocols. Then, as research in this area continues to grow, it is likely that virtual reality simulations will become an increasingly important tool in the rehabilitation of range of condition, not only range of condition, in the entire field of physiotherapy. And not only in physiotherapy, it is going to be worldwide in all the field. This training intervention provides a safe environment for practicing new movement strategies. For like conditions like, we can give some visual, auditory, and tactile sensation cues also giving. And this is the physiological effects, what happens here. The neuronal plasticity will be increasing, which can be shown in the increased cortical gray matter volumes, like higher concentration of electroencephalographic beta waves, and enhanced cognitive performance will be there. This is the neurobiological effects of virtual reality. And this is also the conclusion. So VR enables the creation of virtual environment in which immersion and interaction produce a sense of reality, where users engage and explore the virtual environments in real time. The content of these virtual environments can be created for specific purposes like gaming and for education purposes. And we are using in, I hope so, 7 years before itself they are using in JDT. I heard that. And most of these technologies incorporate precise and robust sensory data acquisition that can be used in wide range of applications, including medicine, sports training, education, physical and mental rehabilitation. The integration of computational intelligence and adaptation with VR technologies clearly demonstrated the prospects of achieving high impact results when combining these elements in application areas such as medicine, education training, and gaming. There are some of the examples they have given, like we are giving haptic sensation. Haptic is nothing but whenever they touch these objects, they will be feeling like that the objects are moving in their artificial environment. Like we are giving visual and auditory feedback also we are giving there, which makes them to feel as real scenarios are happening in front of them. In addition, sensory information from assessment and scoring mechanism, objectively which facilitates the design of more optimum setups with automatically generating user-centered content or we are using. In rehabilitation, we are utilizing this technology significantly, which improves the motor control, sensation, coordination, balance, and also in posture control more effectively when compared to traditional therapy methods. So these are the, this is the thing which I focus, like what is the impact of virtual reality on neurological condition. So these are the main things which we have to focus, like motor control, sensation, coordination, balance, and postural control. See, there are many studies have been done and many review of literatures are there which is supporting this VR. So the reason for this, how it happens. So it is a real-time visual and sensory stimulation and feedback happens. Increased exposure to different environment, heightened motivation and engagement is there. Repetitive motions of functional task is there. Thank you. Thank you for your patient listening.
Thank you, sir. It was a wonderful session. We learned a lot from this. I have a small question for you, sir. Are there any international standards for the architectural dimensions required for a virtual reality setup or a unit of virtual reality if you want to start a rehabilitation unit, as a hydrotherapy unit is having a dimension like that?
Yes,
whether
depends upon this software which we are using, sir. They are having this their own strategies, sir. Like last hour, Dr. Shanmohan sir told like intellectual property rights, no. So which software I was using this Nintendo V software. So they are having one protocol, and apart from that, Rehab Metrics is a software which is using in Chennai setup and Bangalore setup. They are using this Rehab Metrics. So everyone they are having individual protocols, sir. So that's why I am focusing to make it as cheaper cost, which is feasible for our rehabilitation purpose, which should be in all the clinics of physiotherapists.
Thank you, sir. Thank you for the answer.
So, thank you, sir. It was a very informative session, and you have explored the field of virtual reality. So, I just want to ask you, sir, is there any particular criteria or protocol to implement a virtual reality system to a patient, for a neurological patient, such as you have to give semi-immersive or non-immersive or fully immersive for this kind of patient? Is there any criteria? And just want to mention about the duration of this procedure.
Yes, sir. There actually it depends on same thing. If it is an acute stroke patient, as we all know that at the early, when we start the rehabilitation in the earlier stage, there is going to be improvement. But I have seen in 9-month stroke patient, of course, obviously we used to say it is a chronic stage. Even in 9-month stroke patient also, I have used the semi-immersive techniques, and there is a wonderful prognosis. I am planning to do a protocol, sir, and we are planning to get a patent in that. In future, I will try for that, and I will be getting it, sir.
Okay, fine. Thank you, sir.
Thank you so much, sir, for this great session. Thank you, chairpersons, for concluding the session wonderfully. It's time to hand over the memento to the scientific session speaker. For that, I invite the chairpersons. Thank you, sir.
By this, we come to an end to our morning sessions. We would start our last session for the day at 2 p.m. Lunch is being served. All the delegates are requested to have food. The next session on this venue will begin at 2 p.m. All the delegates are requested to be back by 1:45 p.m. I repeat, the next session on this venue will begin at 2 p.m. All the delegates are requested to be back by 1:45 p.m. The lunch is being served. All the delegates are requested to have food.